cause of bankruptcy in the U.S. is due to health care costs. More than 1 in 3 Americans struggles to pay their medical bills.
But Kelly, you met a Utah woman who got some help.
They're saying that they're wiping away about $4,000 of my medical debt. And I was just absolutely stunned.
And we were able to release 2,000 Chicago families from medical debt.
Paul Carlson is the pastor at Calgary Lutheran. His congregation has helped raise around 10 grand to go toward forgiving medical debt, but they can parlay that into over $1 million.
Do this work that we're making a statement about it, that we're trying to point to the system being broken, that people don't feel like it's a personal failing.
We discovered that we already had enough money to buy all of the medical debt that RIP had access to in Iowa at that time.
So far, the church has abolished almost $1.5 million in medical debt, helping almost 1,000 families.
Almost $7 billion of debt have been relieved to date.
Welcome. Thank you for joining the RIP Medical Debt Summit. We're calling this one The Role of Medical Debt in Health. We encourage you to post on social throughout the event, and you can use the hashtag RIP Summit 2022. I'm Allison Sesso, and I am so proud to serve as the president and CEO of this incredible organization that's working innovatively to end medical debt. I thought I'd start our event out today with a couple of statistics to ground us in the realities of the medical debt crisis. First, according to Kaiser Health, there is an estimated $195 billion of medical debt in the US. Medical debt is the #1 cause of bankruptcy. 1 in 3 Black adults have past due medical bills compared to fewer than 1 in 4 white adults. 90% of Americans are insured, yet 41% have medical debt. Unfortunately, and this is the last statistic I'm going to leave us with here, getting sick is the #1 predictor of medical debt, not insurance status. So things are looking bleak. But at RIP, we believe no one should live in fear of medical debt. Worrying about medical debt limits how families unfortunately spend money, make healthcare decisions, and plan for the future. Individuals fall victim to medical debt despite doing everything right. And we know that medical debt disproportionately impacts communities of color, women, and people with disabilities, which is why we are actively building our internal knowledge, culture, and capacity to work effectively in communities more extremely impacted by the medical debt crisis. So I know a lot of you out there are familiar with our work, but for those of you that are not, I figured I'd give a quick high-level view 101 on who we are and what we do. So we're a national nonprofit that's working across the country to relieve the medical debts of people facing financial hardship. We use donations and we purchase large debt portfolios from collection agencies and healthcare providers for pennies on the dollar, on average turning $1 into $100 of medical debt relief. And as of today, I'm happy to say that we have relieved over $7 billion of medical debt, helping over 4 million families. And while we are incredibly, incredibly proud of this accomplishment, and we're going to do everything we can to get as much debt in our hands as possible, we are also acutely aware that we are resolving the problem only for individuals and not fundamentally solving this issue of medical debt, which for us means that we have an obligation to contribute to the larger solutions. So what we're doing at RIP is we're increasingly focused on leveraging our work toward longer-term systemic change. While the direct relief aspect of our work is critical and urgent and will continue, we know it is not a sustainable solution. We've made some very important strategic investments to ensure that we are actively contributing to the larger effort to address the medical debt crisis. And I'm going to share a couple of these highlights with all of you right now. So first, we've hired an anthropologist to support storytelling. What we want to do there is really lift up the voices of those who we've helped and learn from their experiences. We don't want to make assumptions about what it's like to have medical debt. We want to hear directly from the sources and find common themes. What we're trying to do there is ensuring that their perspectives are a central part of the discussions around solutions. And I'm happy to say that this is why we'll be debuting a video today as part of the summit that's centering their stories. The other investment that we've made is really in hiring a seasoned public policy expert who you're going to be hearing from momentarily. And this is so that we can participate meaningfully in efforts to move the needle around systemic change, and that we can contribute effectively from what we're learning as we work with hospitals and learn from beneficiaries what it's like to have medical debt. And we try to be really proactive in adding to the solution-oriented discussions. We're also developing community-based partnerships that aim to connect our work to established community and provider collaborations that are interested in addressing medical debt and bringing the RIP solution to their local communities. And this includes a significant partnership with Cook County government in Illinois. We also are doing all of this work on top of growing our efforts to get rid of as much medical debt as possible and expand our ability to purchase more and more debt and offer as much relief to families as possible. Because we understand that systemic change will take time and people need debt relief today. So we're doing both things at the same time, working on the systemic solutions and contributing to that while also relieving as much debt as possible and connecting those two pieces together. So this summit is really part of our efforts to amplify the harm that's perpetuated by inaction on larger systemic changes. And it's our way of helping to propel some movement forward. So we're going to start the day with a brief update on public policy, which I'm going to be relaying to you shortly. That's going to be followed by a provider conversation on medical debt as a social determinant of health and its impact on patient trust. We'll then have a panel focused on the challenges patients encounter navigating their financial responsibilities related to healthcare and the impacts of financial toxicity on health outcomes. That'll be followed by a short break with that video that I mentioned earlier that's focused on the stories of individuals that have benefited from our relief efforts. And our last panel before our final call to action will focus on potential solutions that can remove the growing financial burden on patients right now. So I hope you're all as excited as I am to listen to these incredible conversations and hear from this amazing lineup that we have in store for you. I think it's going to be quite informative and enlightening. I want to thank our amazing and committed and talented RIP medical debt team, particularly those who worked really hard to put this summit together, but for the entire team who works tirelessly every single day to ensure we fulfill our mission. And of course, I want to acknowledge our board of directors who share their time, energy, connections, expertise, and resources to ensure our organization is financially sound and mission-focused always. A special shout out to Jerry Ashton because he's the one that really started the summit tradition at RIP Medical Debt, not to mention helping to found the organization. So thank you, Jerry. We're continuing in the summit tradition in your honor. So thank you, Jerry. I also want to thank all of our donors, of course, we could not do this work without, and all of the beneficiaries who have bravely shared their stories with us, both privately and in public especially, because that really helps break the stigma associated with medical debt. We have some incredible panelists and moderators lined up, and I want to thank them right now for joining us and dedicating their time and expertise. We have people with a wide range of experience and perspectives, including researchers, practitioners, policy experts, and other industry leaders. I, of course, want to thank our sponsor, Catalyze Health, whose work aligns with our mission because they eliminate all of the out-of-pocket expenses like copays, deductibles, and coinsurance for all employees and dependents enrolled in medical insurance. At RIP, we know that a large and growing percentage of medical debt is a result of these unaffordable additional costs. So thank you, Catalyze Health, for not only sponsoring this event, but for your role in preventing medical debt. And now it is my pleasure to introduce our incredible Vice President of Public Policy who joined us less than a year ago and yet has accomplished so much. She is a longtime leader in healthcare affordability and health equity, and we are so thrilled to have her on our team. So without further delay, and thank you all for being here, I'm going to virtually pass the mic over to Eva Stahl.
Thank you, Allison, for that really warm welcome. As Allison said, my name is Eva Stahl. I'm the Vice President of Public Policy at RIP Medical Debt. And today I'm going to talk briefly about medical debt, its implications, and the RIP Medical Debt Policy Agenda, including our agenda setting process. So as Allison noted, in 2022, RIP Medical Debt expanded its approach to include direct policy work. Specifically, we seek to address the root causes of medical debt in collaboration with a range of stakeholders and provide a unique perspective as an entity committed to abolishing medical debt for millions of people. We are guided by the stories of our beneficiaries as we work to inform and deepen policy conversations about how to make our healthcare financing system equitable and more affordable. As you will hear from one of our beneficiaries today, saving your life should never be based on cost, and we agree. So thank you for engaging with us today and being part of the work to end medical debt. So as we listen to our beneficiaries, we learn a lot about the medical debt experience. As a part of our team and our process, we ensure that our work is rooted in these experiences. Our in-house anthropologist works diligently to catalog feedback from our beneficiaries to inform our policy work. Today, you will have the opportunity to hear from them directly and learn their stories. Creating this feedback loop for us is core to our policy approach. And the feedback loop directs us to focus on three core policy areas. First, affordability and comprehensiveness of coverage. People's insurance is not shielding them from financial harm and stress and is not affordable for too many people. Second, easy access to and enrollment in financial assistance programs. Many people are not aware of financial assistance programs, nor do they complete the application. Third, banning extraordinary collection actions and monitoring medical debt. These type of collection actions are harming people and are disproportionately used in communities of color. Finally, we need more robust data to tailor policy interventions and monitor progress. But first, let's lay the groundwork for our conversation today. Medical debt is widespread and harmful. Allison laid out a few of the statistics, and let me fill them in a little more. Millions of individuals across the country owe an estimated $195 billion in medical debt. It's the #1 cause of bankruptcy. And as Allison noted, getting sick is a better predictor of medical debt than having insurance. Several research surveys have found people are more afraid of acquiring the debt that often accompanies serious illness than they are of the illness itself. Medical debt is burdening real people financially and emotionally, but it does not affect people equally. 1 in 3 Black adults have past due medical bills compared to fewer than 1 in 4 white adults. As we will discuss today, medical debt is a racial justice issue. The harmful effects are significant. Individuals with medical debt are 3 times as likely to have a mental health problem and experience stress. It is worth repeating that medical debt is involuntary. It is a debt of necessity. Despite recent changes to credit reporting, we know that medical debt continues to harm people's credit and therefore their access to mortgages, credit cards, loans, and employment. And there are a number of reasons why we're in this crisis. Despite the expansion of access to coverage, thanks to the Affordable Care Act, many people remain uninsured and cannot afford their coverage. Of note, recent data shows that Medicaid expansion reduces medical debt as much as 44%, yet several states have failed to make Medicaid available to the poorest among us. In the private insurance markets, some healthcare needs are simply not covered or severely limited, and the growth of high deductible plans is leaving many people left managing unaffordable deductibles and copays when they access care. Even our safety nets are fraying. For hospitals, the pandemic has stretched our provider workforce and systems face unprecedented burnout. And for patients confronting economic uncertainty, access to charity care is not always straightforward, and eligibility can shift over time. Furthermore, charity care is often only available when receiving care at a nonprofit hospital and can have many exclusions, including for key services people expect hospitals to provide, like anesthesiology, OBGYN, or orthopedic care. Other types of providers may not offer financial help, with massive consequences for people with chronic or serious illnesses and people with disabilities. Finally, our approach to collecting overdue medical debt can be harsh and weighted to favor the industry, not the patient. Medical debt is often lumped in with other debts, despite being involuntary. And while we know that from our beneficiaries that they both want and attempt to pay their bills, most people don't have the savings to do so, leading them to borrow from friends and families, take out a loan, or put on their credit card. Our policy agenda attempts to respond to these problems. First, affordable and comprehensive coverage. People need lower out-of-pocket costs so that health insurance is truly affordable. The surge in the ACA plan enrollment highlights the importance of affordable premiums, but we need to do more to address out-of-pocket costs for all insurance markets. A proven way to address medical debt and advance racial equity is for states to close the Medicaid coverage gap. Other ways to improve affordability include removing barriers to full family coverage, as the administration did yesterday by eliminating the family glitch through the ACA, and investing in outreach and enrollment, and identifying ways to ease enrollment in and selection of health plans. This includes investing in navigators and consumer assistance programs. Second, easy access to and enrollment in financial assistance programs. To reduce burden on staff and improve patient experiences, hospitals and providers should leverage tools to make enrollment in financial assistance programs seamless. And because medical debt causes such anguish and stress, notifying patients as to whether or not they are eligible for charity care or have other options for financial support is critical. Hospitals and providers should ensure that they are considering medical debt as a social determinant of health, integrating financial assistance resources into that workflow. Finally, banning extraordinary collection actions and monitoring medical debt. States and the federal government can prohibit the most egregious debt collection practices, and hospitals can opt not to use them. These tactics range from wage garnishment to litigation and are harmful. Emerging research shows that these tactics disproportionately harms communities of color and low-income people. Finally, states and the federal government can and should play a more instrumental role in data collection and monitoring medical debt. The data gaps are truly significant and are a barrier to targeting policy solutions. Medical debt is about failures of policies and systems, not people. We commit to elevating the voices of our beneficiaries and work with all stakeholders to navigate challenging policy conversations to end medical debt. And we have asked our panelists today to do just that. From patient trust to inadequacy of our coverage system, panelists will discuss the challenges of operating in a broken healthcare financing system and explore how we identify areas of consensus to eliminate medical debt. We're grateful for your time today to begin that work. I'm excited to shift us to the next part of our program and briefly introduce our next two panels. Up next, our provider roundtable will be moderated by Dr. Oxiris Barbeau, the president and CEO of United Hospital Fund and former New York City Health Commissioner. And she is joined by Dr. Ram Raju, former senior vice president with Northwell Health and CEO of the New York City Health and Hospitals Corporation. He also served as the CEO for Cook County Health and Hospital Systems in Chicago, the nation's third largest public health system. And they are joined by Dr. Rishi Manchanda, CEO of Health Begins. His organization helps leaders and frontline caregivers to understand that moving upstream means continuously improving the social drivers of health and equity at all levels. Directly following the roundtable, we will listen in to our first panel. Led by Kaiser Health News journalist Noam Levy, we will hear from a great set of experts, including Jared Walker, the CEO from $4, Bernita Haynes, attorney with National Consumer Law Center, Dr. Veena Shakaran, co-director of the Hutchinson Institute for Cancer Outcomes Research and professor, and Dr. Ray Kluender, economist from the Harvard Business School and faculty affiliate at Abdul Latif Jameel Poverty Action Lab. You can learn more about each of the experts of the day on our website, ripmedicaldebt.org/summit. Again, thank you for joining us and enjoy the day.
Yeah, can you hear me?
Can you hear us?
Yes. Yes.
Yep. Can't hear you now. No. Sure. No problem.
Okay, that's fine. I think Dr. Barber will join us soon. So, hi, Rishi, how are you? And nice to see you. And we are here to discuss something pretty important to both of us because we have been in the journey for a long time trying to create health equity through addressing social determinants of health. And as Eva spoke about, that social determinants of health is greatly influenced by medical debt. So glad to be a part of that. So maybe the first question would be that we want to discuss with Dr. Barbo, send it to us is, can you narrate the experience in your life, in your practice or in your professional life, how the medical debt actually interfered or produced negative impact on some of the health conditions of the patients you dealt with? Some examples if you got.
Thanks, Ram. Yeah, thank you so much. And I know that we're filling in ways that we certainly can never do for our moderators right now. So we'll continue dialoguing, but I know I'm especially privileged to be joined by both you, Ram, as well as Dr. Barbeau. So I'll just, not yet. Yeah, not yet. But let me go ahead and jump in with a question. With answering the question here, I think, when it comes to trust, the impact on trust, I'll start by sharing a quick story. I'm a primary care physician. I trained as an internist and a pediatrician, and I went to go work as part of the National Health Service Corps in historically marginalized communities that have been harmed by societal practices. I had the privilege of caring for families in South Central Los Angeles as one of the first opportunities out of residency. And day in, day out, I saw the financial toxicity that harmed my patients and particularly impacted their health. It also made them, of course, skeptical of recommendations. If we needed to send someone for an evaluation with a cardiologist, for example, for a heart murmur that we picked up in the primary care practice, or we needed to engage a specialist to help with chronic obstructive pulmonary disease, right, COPD, or an oncologist to help somebody who is newly diagnosed with leukemia. The immediate kind of skepticism that would come up was a symptom of a sign of a deeper experience of harm that many patients who've experienced financial toxicity, who've had to struggle to make ends meet, have had with the healthcare system when they've gone to expensive, high cost, and sometimes actually extractive systems, right? Places where they know that if they go, they might get hit with a bill, and that bill might set them back a month, 2, 3, 4 months, or even more in terms of their ability to pay rent or food. And so, it certainly has an impact on trust, but that's because of what medical debt really represents, which is a form of harm. When you've been harmed, when you've or perceived the threat of harm because of stories that have impacted your families, your neighbors, your friends.
Very well said.
Very
well said, Rishi. I think an experience of mine would be that, I'm a surgeon by profession, and I operated on a very nice lady, Hispanic woman, who has been so grateful for the services we provided. And she had a cancer surgery, needed some chemotherapy. And somehow she didn't show up for chemotherapy. And as you know, in health professions, we don't understand the patient's issues that well, especially the social issues. So she will be kind of portrayed as a non-compliant patient. That's what usually we kind of use this term pejoratively to do that. Then when I really looked into that, the reason she was not able to attend the chemotherapy because her landlord increased her rent and she can't afford to pay that extra rent. And then she was afraid that if she leaves home to get chemotherapy, the locks may be changed and she will be rendered homeless. So she chose not to go for chemotherapy and risk the recurrence of cancer. That's because of the lack of or the ability to pay the extra rent. So these kind of things, as you rightly pointed out, kind of stick with you in your brain, and that really makes a big difference. How much the medical debt impacts the outcomes of the patient. Now we got the moderator back, I think. So great to see you, Dr. Babu. Dr. Babu, still we cannot hear you.
Sure.
Okay, sure.
Yeah.
So Rishi, I think those are some of the areas where we were really able to impact, and your journey has been pretty extraordinary. In fact, we interacted with you in a lot of those forums. So the second one is over the years, especially there is an article right now published that how the medical debt impacts the social determinants of health to a greater extent. So we know that the lack of transportation, the food insafety, the food insecurity, and the stress and the poverty, and to add to that is the structural racism and the marginalization of the certain group of people have all contributed tremendously to the social determinants of health. So what is your take on that? And what is the take-home point you think that we need to understand how the medical debt impacts the social determinants of health?
Yeah, thanks, Ram. And I'll chime in a little bit, but before I chime in, let me check again with our moderator. Okay. Not yet. Yeah. Well, I'll jump in and share a little bit of a framing, and I really want to start by actually just describing first. I think the study you're referencing is a phenomenal one, and I hope that folks are able to look up the study that recently published by David Himmelstein and colleagues, describing the ways in which medical debt was actually associated with worsening food insecurity and other social needs among patients. It's an important bit of research. It's not shocking, however, for those of us who understand the issue of health equity by understanding that there are social, institutional, and structural drivers that create health inequities. From this perspective, actually, it's important to understand medical debt not just as a glitch, not as a side effect, but actually as a specific byproduct of healthcare in America. Debt is baked in as a feature, not as a bug in U.S. healthcare. And as such, because it disproportionately harms low-income and middle-income Americans, especially Black and Latino and other people of color, it is therefore only to be understood and best understood as a form of structural violence. What I mean is medical debt is something that a patient or a family might experience, but medical debt is itself a part of a structural form of violence that extracts wealth and thereby causes harm to people who are already marginalized by other societal practices. And if we understand it that way, what we need to then understand is, first, it's not surprising then to see that medical debt is a way in which healthcare is itself contributing to harm, disproportional harm. And that's especially important in this day and age as more and more healthcare systems rightly elevate the priorities of health equity, of racial equity, of racial justice, including in public statements. And as more and more healthcare systems and payers are looking at the social needs and the social determinants of health in the communities and trying to invest in that. So let me put it this way. On Monday, if a healthcare system is investing in screening for food insecurity and putting investments into affordable housing in the community, but on Tuesday, they're then suing patients because of sometimes the very same patients that they're trying to help because of unpaid medical debt, we have to ask, is there a disconnect? And the answer obviously is yes. So I think it's important for us to understand that medical debt is an iatrogenic form of structural violence. It's something that is happening by virtue of the way we've set up care. And because of that, I think we're going to see a lot more research that I think continues to make clear what, frankly, those in social science and those who've been looking at the economics of this have long known. And that is that medical debt is one of the biggest drivers of not just keeping people in poverty, but driving Americans into poverty every year. Yeah. From that perspective, I think this research is powerful to understand.
That's very well said, yes.
Go ahead, Ron. Yeah.
That is very well said, Rishi. I think it's very well said. I think the issue we are dealing with is that, you talked about poverty, how the intergenerational poverty is a major factor in contributing. And apart from also the structural racism which built into this, into healthcare delivery systems, unfortunately, and everywhere, and especially healthcare delivery system. So you are right that it does have a greater impact on the access to care and also the access to get better, right? And they're also able to access the care and also get a better outcome. It becomes a bigger problem for all of us. I think it makes a very big difference of how we do that. I think I got a moderator back, I think, so probably we should defer to her. No, Akshay, I'm sorry. Akshay, you're still not on. I'm sorry. Yeah, okay. So the question what we have to deal with that is this is the problem, Rishi, and we have kind of dealt with this in a way, and how this food insecurity, and the inability of the money need to buy healthy food in this country, unfortunately, is so expensive, whereas the food which is not good for you, which promotes child obesity, like the fast foods, are so cheap. And then we not only have food deserts in this area, but we also got food swamps where a lot of this, fast food restaurants and fast food chains are mostly located in a very economically deprived neighborhoods, and that is a business plan. So we not only had food deserts, and they also developed food swamps, and that actually, this money issue has actually driven people to get those kind of food because that is cheaper and also they can afford it. Whereas the healthy food, unfortunately, we have not made it accessible and cheaper for people to get that done. So that is the point I think I wanted to make. So with that in mind, we want to move into how can we help the healthcare organizations can deal with that.
Yeah, Ram, I think
the importance of medical debt in the healthcare organizations. How can you as a provider can educate them?
Yeah, I think there's I can start by just putting, what I call the 4 R's on the table, the 4 R kind of steps that can be helpful here. And, I think the first is to review. The second is to remember. The third is to push for reforms and provide redress. That's maybe 2 R's there. And then the last is reimagine. Let me unpack what I mean by that briefly here. Review means the first R, to review what providers can do, especially those who are, whether you're an informal leader or you're a formal leader in a healthcare system or in another healthcare entity. Review how your hospital or your healthcare system measures up when it comes to predatory financial practices or other practices that are now driving up medical debt, particularly for those who should not be charged in the first place, those who qualify for free care. It's part of a social compact we've created in the U.S. The Lown Institute has a wonderful hospital index that measures and ranks healthcare institutions according to how socially responsible they are. That's a really good index now to use to start the review process. Another way to review is to look at a recent report by our friends at Families USA that reviewed the fact that more than 80% of nonprofit hospitals and healthcare systems spend less on charity care and community investments than they do compared to the tax breaks they actually receive as nonprofits. It's important to review. What does this mean actually if if our healthcare systems themselves might be driving predatory financial practices, if we're suing patients, especially poor patients, if we're putting more people into debt? Oftentimes what I find is that the champions of health equity, the champions of affordable healthcare, the champions of high quality care, of patient safety, these incredibly dedicated physicians, nurses, social workers, and other kind of healthcare professionals inside health systems oftentimes are disconnected and sometimes maybe kept away even from looking at the books and the financial practices. And I think it's time we need to get past that. We need our champions of health equity to start turning inward and reviewing. The second R is remember. Remember to do no harm, especially if your hospital already has the social determinants of health social needs or health equity strategy. We believe that hospitals and healthcare has a responsibility to provide the highest standard of care by integrating health, behavioral, and social care. We also believe that hospitals, of course, I think many now recognize that hospitals have an important role to play as employers or as funders or as partners or even as advocates to promote health equity in communities. We applaud that. A lot of my work at Health Begins with my colleagues and our partners across the country supports that. But we have to remember as we move upstream to advance health equity to ensure that we are using a do no harm approach, to make sure that we are challenging and reviewing internal practices that might be, including high prices that keep on driving these predatory financial practices. If we can start by actually making sure we do no harm, then we can ensure that our work for patients and the communities is now consistent with our financial kind of practices. Let's do no harm and adopt that as a model. And I can talk about the other R's in a second, but I'll pause here and see first if Oxy's on board or if.
I think you made some very valuable points. But as we all know that people tend to associate this medical debt only with people who got no insurance. But more and more people who are on a high deductible plans are also incurring medical debt. These are the very hardworking people because the inaffordability of a comprehensive health insurance package, sometimes even offered by the same healthcare institutions. The people tend to choose a high deductible plan and they end up with a huge amount of medical debt to the same organizations. So especially now we have such a difficulty in getting healthcare workers. There is a huge healthcare worker shortage. Hospitals need to think about it, that investing and making people take a very high deductible health plan actually increases medical debt. Do you have any views on that, Rashid?
Absolutely. I think one of the things that's, as prices are going up, obviously, hospital prices across the country have been, healthcare prices in general, I should say more broadly, have been rising at a rate that's 4 times faster than worker wage increases, right? In the past decade, far outpacing kind of cost of living or inflation right now. So price increases are driving a lot of both predatory practices that are driving medical debt and debt collection in ways that are unfair and harmful, but it's also driving and very much associated with, to your point, another way in which people are getting hit with medical debt, and that's the out-of-pocket spending, especially for those who are in high deductible health plans. I 100% agree with you that another main mechanism that providers and advocates in general can take is to work with many other organizations that have been, including employers, coalitions of employers, right, who have been advocating for both value-based insurance design and even models to look at health benefits that are tied to wage, that are a progressive kind of scale based on how much you earn, your wages, rather than high deductible health plans that increasingly now actually look more like catastrophic insurance, right? Where people try to keep their month-to-month kind of expenditure on the premiums pretty low, but essentially forced into a position to gamble, right? To take a risk every day to hope that they don't get sick or incur a healthcare expenditure. So I agree with you. There are steps to be taken, especially in alliance with those who care about the same issue as employers, both within and outside of healthcare, to start controlling the amount of exposure to risk by providing alternatives to high deductible health plans. There's many steps that we can take as both employers and as advocates to help reduce the amount of risk, the amount of harm that is driving people to medical debt through high deductible health plans as well. I have no doubt that that's a step that healthcare providers can take, starting within their own institutions. And I applaud what you're suggesting as well, which is that a way to do no harm, especially for those that you employ, is to make sure that you're assessing how much financial risk your own employees are at for medical debt. I think we have.
That's good.
I think
we have our moderator back.
Oh,
okay.
Great.
But I can't hear him.
Can you hear me?
Okay.
Oh, sure. Okay. So one of the things I think talking about it is that we really created these high-end plans because we thought that it looks pretty interesting at the beginning because they get you little money, but they hit you with a large amount of money in the back. And that creates people not seeking care, right? Because I have a high deductible plan, so I tend to not to go to a doctor because I have a very high copay. Because not seeing a doctor, I got to pay like $100, or I got to get I can't go to the emergency room because I have the first $5,000 is on me. So that is impossible because the people really living from paycheck to paycheck, doing honest work, that becomes a problem. So how do we as a policy makers trying to help us to have this? Because when people tend to sell insurances or the mortgages to people who can't really afford it, not explaining the whole problem, we tend to sell this high-end, high-deductible insurance plan to people without just explaining to them completely that it could be a disastrous plan in the end because you may end up with something. Or we have some rider which has got some catastrophic rider saying that, okay, if your deductible goes beyond X amount, then we are going to come in and help you, something like that. You see anything in the horizon with that?
Yeah, I think first, this is we have to, in some ways, unpack one of the drivers, not the only driver, for why we're seeing this happening right now. The reason that premiums and out-of-pocket expenses are going up, especially for those who have high-deductible health plans, is because of the increase in prices. We have to talk about prices, especially among hospitals, right? Hospital price increases right now are directly linked to some of the cascading kind of impact on the bottom line for plenty of Americans. It's not a surprise that nearly half of all Americans with insurance can't afford their deductible due to the rise of high-deductible health plans right now. Right. Let me just state that again. Nearly half of all Americans with insurance, right, can't afford their deductible due to the rise of high deductible health plans. And that means that, therefore, we can take steps. We can advocate for value-based and wage kind of based insurance benefits and workplaces through coalitions of employers. So you have national associations, regional associations, organizations like the Pacific Business Group on Health and other employer coalitions that have bring some of the biggest employers in the country together who are essentially saying, look, we want to make sure that while we're pushing from a value, that we aren't actually harming the people that we employ. And this is important because now we're seeing from a lot of different stakeholder groups a recognition that high deductible health plans by design are not equitable, right?
Yes.
And are driving inequity.
Is Oxy back?
Another thing we can do
Yes.
I love your thoughts. Oh, go ahead. Yeah.
Oh,
Oxy,
finally, thank you.
Hey.
Thank you. Good to have you, Oxy.
It's good to be here. And I have to say that after 2.5 years of doing these webinars during a pandemic, I have finally come across a platform that has stumped me. So I apologize to the audience and you, Ram and Rishi, for so elegantly just picking up the baton. And I appreciate that. And I've gotten a lot of what you've talked about, but I wanted to sort of go a little bit deeper on the study that you alluded to. And it's a study by David Himmelstein et al. That came out in the latest September issue of JAMA. And I think it's worth repeating. I know that you did reference parts of it, but it's worth repeating that 1 in 5 households in the U.S. carry medical debt, and that on an individual level, it's roughly about $2,300, and at the household level, it's roughly $4,700. And that while we may typically think of low-income individuals carrying medical debt, the reality is that middle-income folks are also carrying medical debt. And I know that when I came back into the conversation, Rishi was talking about the issue of high deductible plans. And so I wanted to really emphasize that though the uninsured are most likely to carry medical debt, they are followed by individuals that have private insurance, but that have high deductible plans. And additionally, that in the elderly population, what we see is individuals who have Medicare Advantage plans also being subjected to higher rates of medical debt. And then lastly, in terms of what that particular study illuminated for us, was that people that are in non-Medicaid expansion states were 40% more likely to carry medical debt as compared to people in Medicaid expansion states. And so I don't know if we've gotten into the conversation of the importance of Medicaid expansion, but I think it bears repeating that there are structural remedies to work on medical debt. The other thing I wanted to just highlight for the audience and incorporate into our conversation is that, increasingly additional research shows, excuse me, that medical debt is obviously bad for health and interferes with the provider-patient relationship around trust building. And I'm really glad that, Ram, you brought up the issue of how if we don't talk about the issue of medical debt and the concerns around that patients may have about not incurring medical debt, that we can then, from the medical system perspective, label patients inappropriately as non-compliant. And so therein is yet another reason why it's important for us to normalize conversations around medical debt, put on the table fears that patients may have when they talk to their providers, and create structural opportunities for healthcare systems to reduce medical debt in the first place. And so our hope is, as we continue this conversation, that the audience will have a deeper understanding of how medical debt and the fears about cost disrupt developing patient-provider trust and caring relationships. Understand that in addition to housing, transportation, education, and other things, that medical debt is a social determinant of health. And then hopefully through our conversation, we can identify additional practices and consideration for addressing medical debt in the clinical space. So again, I apologize to the panel and the audience for breaking up the flow of the conversation, but I thought it was important for us to kind of get those big picture stats out there and sort of helping us to level set what it is that we are talking about, what it is that we want people to get out of this conversation, and how it is that we can create opportunities for broadening what it is that we consider when we talk about medical debt. And I think, Rishi, the points that you have brought up about the violence and the harm that medical debt causes patients is something that I don't think we talk enough about, and that we have to be mindful of when we're striving to create more caring systems. So I'm glad that you were able to introduce that into the conversation. So if you guys can help me figure out in which one of our questions we're at, and then I can take the reins.
Yeah, sure, please. Happy to hand it over. And we are in the last part of the question of best practices we want to share, and then we have a closing. So, but again, you are free to ask any questions you want.
No, so why don't we continue the conversation about best practices?
So let me start. Some of the best practices need to evolve from what I call as taking a closer look at the charity care policies of the hospital systems. Because every hospital system used to have a charity care policy. And for example, when I was in health and hospitals, our charity care policy extended to 400% federal poverty limit, so that we understood that working poor are also live almost in poverty, and they live paycheck to paycheck, as well as the people with no jobs and people who has got no other income. So we really expanded the charity care pool to include that. And our ability to do that will be a part of it. And the second part we did in health and hospitals are also that, when the patients come in, we always had a financial counselor meet with them and then talk to them about various options available, charity care policies. And if they are eligible for Medicaid, some of them didn't know they're eligible for Medicaid, then we took the took it upon ourselves to get them the Medicaid, so that not only help them with the healthcare, it also gives them the other benefits that they can get food stamps, they can get other benefits of Medicaid as a part of it. So those are two major best practices. We have found it to be extremely effective in addressing the medical debt at the end, at the front end, not at the back end, because a lot of organizations basically end up incurring a medical debt and go through the torture of being inability to pay for it, and then they say, okay, we are going to help you with something. But I think hospitals should proactively give them a much more generous charity care policy, and number two, a financial counseling upfront, so that they are able to manage their medical debt and able to get the resources available to them. Thank you.
Terrific. Thank you. Dr. Manchetta?
Yeah, thank you. So I think just building on Alaram's great points, I'll point to a couple of resources that I found very, very helpful in my work. One is our friends at Community Catalyst have done a really great job of, for a long time, both calling attention to the harms of predatory billing and financial practices in healthcare systems, and providing recommendations on best practices here. So would definitely recommend looking at Community Catalyst, especially some of their work to, as they say, do no harm. One of those includes improving screening, just to make sure that we're identifying those who might benefit from a program like Medicaid or marketplace coverage, and making sure that we're not assuming that a patient needs to be the default, but assuming instead that there may be a default payer in the workflows. There's a variety of steps that boards of healthcare systems, frankly, need to take as well. First is learning about this issue. Not enough hospital boards right now have enough pressure right now, or perhaps are demonstrating enough leadership to be able to look at this very seriously from an equity lens, and to say, let's stop the harm that might be happening here through our financial billing practices. Boards need to play a more active role in their fiduciary oversight responsibilities, and the responsibilities to be able to look and see if there are these practices that might be actually putting families, including historically marginalized families and communities, at risk. That takes responsibility of leadership transmitted through formal reports to see how billing and collection policies might be harming patients. That report is not something that should only be reviewed by boards, but also should be made accessible in public, both to regulators as well as to patients. We have a lot of patient family advisory councils, for example, in a lot of healthcare systems. Very few of them have actually been presented reports on the disproportionate impact of unfair billing and collection practices. So those are steps to take. In other words, use
thoughts about incorporating the issue of medical debt into the indicators that we think about when we think about quality indicators. And we're talking about here how medical debt influences health outcomes, both as it relates to social determinants of health, but also in terms of potential practices within healthcare systems. And I think you rightly point out that what doesn't get measured doesn't get managed, and that dealing with the issue of medical debt really needs to start from the very top. And Rishi, I'm glad that you brought the issue of hospital boards, but then also thinking about how we engage all aspects of healthcare systems in normalizing the conversation about whether or not patients have concerns about how and if they can afford their care, and building in reassurances that medical debt isn't going to land someone in a worse clinical situation than they started with when they first came into the office. And so I'm wondering if in both of your experiences, you have come across health systems that have taken a more holistic approach in terms of tackling the issue of medical debt in their systems.
Yeah, I'm happy to go first if that's helpful.
Yeah. Sorry?
Sure.
You want to go first, Rishi?
Yeah, I'm happy to go first. So there are good examples actually of health systems that are that are taking these steps to both review medical debt and see how they can now bring in quality, patient safety, population health management, community benefit leaders within their enterprise, along with, of course, the financial and revenue kind of teams and billing teams together to be able to look at the data. I think of a person that I've learned a lot from over at Bellin Health, Maggie Koch, Koch, Maggie. She's great. Maggie is somebody who's been active at Bellin Health up in Wisconsin for some time, and they looked from a quality improvement perspective years ago at these questions of debt and impact on patients, and then started to think about how to reduce the harms of poverty, in part by assessing their own financial practices, not just to be in compliance, right, with state or federal regulations, not just to make sure that the right forms are available to patients in a room, but to actually, from a quality, safety, health equity perspective, look at a driver that's almost directly within their scope of control, right? And think about how they can adjust that, how they can evaluate, first of all, if there's an impact, and then adjust that. So another example of health systems that have an opportunity to do this are those health systems coming together in a number of the various collaboratives around health equity that have formed in the country. We have the privilege of being faculty for a network of health systems organized by the American Medical Association, a peer network for quality and safety leaders across wonderful vanguard institutions in the country. And a lot of what they're doing from a patient safety and harm reporting kind of vantage point is to evaluate in their data and in their processes if there are ways in which structural violence is manifesting as harm in the lives of their patients. And that means actually looking with rigor to say, hey, is there something, not just if there's a patient who's harmed or if there's a patient complaint, how do we create systems where we're tagging not just, is this because of a staff issue, a poor communication between a provider and patient, but also if there's something within the institutional practice, is there something related to something our institution is doing that is contributing to that harm? This is where medical debt becomes a helpful part of a review process in the patient safety and harm reporting kind of systems. In other words, each of our systems in healthcare has an opportunity now to look at medical debt as a contributor to harm and to review our data systems to see if we can identify when the patterns of harm are taking place and when they're correlated with medical debt, and then to use that data then to fight for the reforms to improve not just financial health for patients, but improve quality, population health, and health equity outcomes.
Terrific. Thank you. Dr. Raju?
Okay. I think those are very, very good points. I think we have, after so many years in my last job, I was able to bring in the social issues into the electronic medical record and be able to combine the social determinants and be able to risk score them and be able to deal with them as the providers deal with the medical issues, the systems deal with the social issues, thereby showing that we are able to better manage the patients with better outcomes. But to do the thing, what we are trying to do in medical debt, we need to incorporate the financial system into the quality assurance system of the hospitals. We started doing that, but when the initial encounter has been a little bit difficult or also messy because what we call as account receivable in the financial system, that is the money that's supposed to come into them. It is very difficult to differentiate on a minutiae basis how much of money is coming from insurance companies and how much is money coming from self-pay and how much of that money is really bad debt and charity and how much of money is being medical debt. So we have to have real tools and real definitions to differentiate the medical debt from the charity care and able to measure it. I think once we reach that kind of sophistication in the healthcare delivery system, then getting that medical debt and then linking it directly to the outcomes in diabetes, outcomes in high blood pressure, and outcomes in other things will probably yield, I'm sure, great insight into the social determinants of health and how much a medical debt plays a role in that.
Terrific. Thank you. So I wanted to leave a few minutes for us to have any closing summary remarks about our experience as healthcare providers dealing with the challenge of medical debt and ensuring that it didn't inappropriately become a confounding variable, if you will, in the patient-provider relationships that we were trying to cultivate with our patients, both on an individual basis, but also at the systems level. So I'll start with Dr. Machado, if you want to take us and give us some of your summary reflections on this issue.
Closing thoughts, if you will.
Yeah. I'll give you about 2 minutes.
Okay, so I'll say here that kind of recap the steps I think we can take, and I'm speaking specifically to my kind of colleagues, all of our colleagues in healthcare in particular, who whether you're a professional, a practitioner, or you're an administrator, or you're a policymaker, we all have a certain mission right now that's brought into this work. And if you're in this particular room right now, virtually with all of us, I want to speak to 4 steps that I think we can take and we can encourage those that we support to take. One is review. I mentioned this earlier. We have to start looking at the data ourselves and being able to see how we score when it comes to measures of equity, and particularly looking at financial practices here. There are the Lown Institute, reports from Families USA, and a number of other organizations that can point us to benchmarks for evaluating how well we're doing, particularly when it comes to the existence of harmful practices that are driving medical debt and other forms of healthcare profiteering that are unfairly extracting wealth from some of our poorest and middle income kind of patients. Reviewing where we're at is the first step. The second is reforming. We've got to push for changes to hospital financial practices, and that includes making assessments of who's been harmed by these things. So that means looking at the billing and financial practices. Again, I think a lot of discussion today is going to be about what best practices look like. We've talked a little bit about that today. I recommend our friends at Community Catalyst, who've done a great job in outlining some of those. Third is redress, not just reforming practices, but provide redress. If medical debt is the most concrete kind of manifestation downstream of the upstream structural form of violence, which is healthcare profiteering, right? Then we need to start counteracting that by first acknowledging and providing redress to those. From a harm perspective, if you harm somebody, if a patient is harmed by a hospital or by a caregiver, our first step is to apologize and then to provide redress. Medical debt is harming patients, and we need to provide redress, whether it's through direct cash transfers, frankly, paying people who've been unfairly kind of sued or billed back the money that they're due, or also taking other steps like through medical financial partnerships to make sure that those who are harmed or at risk of being harmed by medical debt are getting the support financially that they need. There's ways to provide redress. And the last R is reimagine. All the steps we take within our institutions are necessary, but won't be sufficient unless we push for the policy changes at a state and certainly at a national level here. It's time to make sure that we reimagine state and federal policies to rein in abusive price increases, improve true kind of competition to lower healthcare costs rather than pushing against market consolidation that aids and abets in healthcare profiteering. We need to challenge where appropriate and where the data is clear. We need to challenge the nonprofit status of hospitals that are abusing that status rather than serving the needs of communities. And finally, that means includes looking at policies like hospital global budget payment models. We've seen experiments with that in the country, cost containment commissions, and oversight bodies. California just recently announced an Office of Healthcare Affordability. There are other models of this across the country. We need more policies, more accountability to make sure that the healthcare profiteering that is driving medical debt downstream is checked, because the harms are far too great.
Thank you. And Dr. Raju, I'm going to hold you to the 2 minutes as well, please.
Absolutely. I did only 1 minute. I think Rishi was very, very eloquent in talking about it. But I just want to emphasize one factor is also education. In fact, we used to be very proud, and we call ourselves, our doctors are insurance blind. That is supposed to be a mark of, thing that we don't discriminate based on insurance. I think it's a time to teach our medical students and the doctors about the medical debt, the cost, the financial burden patients face which has to be a part and parcel of interacting with the patient. So we cannot keep our doctors blind anymore about anything and then claim that that is a good thing that we are insurance blind. We treat everybody equally, that we should treat people equally, but we also understand how their social issues impact their medical care. Thank you.
Something that I was also going to contribute, that it's important to build into medical education from when people are medical students all the way through residency to understand the impact of medical debt on their future relationships with patients. And that when we are in clinical settings and a patient asks us, how much is this going to cost? It puts us in a very challenging position if we have to end up saying, well, it depends. And as you can well imagine, that can start eroding trust when we start saying things like, well, it depends. So with that, I want to thank each of you for your insights on this topic and how it affects patient-provider relationships. And I want to thank the audience for joining us. Up next is the panel Case Critical on the Front Lines of Medical Debt. So thank you all very much.
Thank you, guys.
Mom, are you crying?
No, sweetie, just some allergies. Come here, let's go play. Come on.
1 in 4 Americans had trouble paying a recent medical bill. Many of these people affected work for companies just like yours. Start giving your employees 100% medical coverage with Catalyze Health.
Oh, sure. Hi, everybody. Thanks so much for joining us for this panel called Case Critical on the Front Lines of Medical Debt. We're going to be talking today a little bit about what the impact of medical debt is on patients, their health and their finances, their mental health. And we have a really, really exciting group of panelists here with us today. I'll start off by saying my name is Noam Levy. I'm a senior correspondent at Kaiser Health News. We've been looking at this topic of medical debt this year in partnership with NPR. And while I've been covering healthcare for the better part of 15 years, I think it's fair to say that all of us who've worked on this project on medical debt have been stunned actually at just how widespread medical debt is in this country. 100 million people have some form of medical debt, we found. So let's get into this right away.
Can't hear
Can you hear me now? Sorry, I think we might be having a little bit of trouble. Okay. Sorry about that interruption. So I want to get right into this. There are detailed biographies of our 4 distinguished panelists online at www.ripmedicaldebt.org/summit. So I won't go into them in great detail, but I'll mention each as we get to them. Let's start with Dr. Veena Shankaran, who has worked extensively as a clinician and as a researcher on the impact that medical debt has on patients with cancer, which I think it's fair to say is sort of one of the uniquely cruel aspects of our system, that on top of life-threatening illness, our health system also subjects millions of cancer patients to the strains of dealing with medical debt as well. Dr. Shankaran, do you want to start by talking a little bit about the research that you've done and sort of summarizing the impact on patients' health, physical and mental, that you've seen both as a clinician and as a researcher?
Yeah, absolutely. Thanks so much, Noam. I would say that when I started practice about and research about 15 years ago, there was very little information about the financial impact of cancer. And I think cancer, we recognize this issue as clinicians, as providers, but really very little had been done to describe the problem. And I think cancer is unique because it is not only very costly, but there's a significant impact on employment and income. And the therapy is often chronic over years, sometimes limiting people's ability to maintain a source of income, and also depleting savings and assets along the way. So our initial goal with our research was really to understand, the prevalence and incidence of financial hardship and debt in patients who are dealing with cancer, and really trying to understand the problem, not just retrospectively, but prospectively. When and how often are these issues happening? Maybe we'll just highlight a couple studies that we recently published. One in which we surveyed patients with colorectal cancer throughout the country. So it was a national study over the course of a year. And we found that about 75% of advanced colorectal cancer patients, 98% of whom were insured, faced major financial hardship, such as medical debt, 20% or greater loss of income, selling or refinancing their home, or having to borrow money from family and friends. And this was far in excess of what we had previously seen in the literature. And another study in which we looked at the incidence of adverse credit events in patients with cancer versus individuals without cancer. And we found a significantly higher rate of things like collections, repossessions, liens, and so forth. So, I think these studies have really emphasized that this is a major problem among cancer patients. Cancer patients are probably more affected than people with other chronic conditions because of the reasons I mentioned. And I think this has really spurred the oncology community, at least, to try and think about interventions and solutions.
Thanks so much for that perspective. And I want to come back to a couple of things that you mentioned, but let's go through our panelists first. Bernita, let me turn to you next. Bernita works at NCLC, where she's done a lot of work looking at one particularly pernicious aspect, I think, of our medical debt problem in this country, and that is the degree to which it has fed racial disparities, which not only in health but in wealth, and creating something of a vicious cycle in this country. Bernita, do you want to talk a little bit about kind of what your research has shown, and then you also have some frontline experience sort of seeing what this looks like on the ground. Tell us a little bit more about that as well.
Yeah, hi everyone. It's great to be here today to talk about this unfortunately always pressing issue. I'm a staff attorney at National Consumer Law Center, where I have been doing some research and digging into the racial impacts of medical debt in particular. And I'll get to some of the frontline experience I have that Noam just indicated in a second. I'm sure it's no surprise to anyone that Black households carry more medical debt than other groups. The whole idea that when America catches a cold, Black folks catch the flu. It's also relevant in the medical debt space, and actually overly literal in some ways. But 1 in 3 Black adults have past due medical bills compared to 1 in 4 white adults, for instance. A lot of that's connected to lack of health insurance. 17% of Black adults lack health insurance compared to like 12% of white adults. But these types of disparities in medical debt are both impacted by systemic racism and also feed into systemic racism. So gaps in wealth and health intersect to worsen the crisis for Black folks, the medical debt crisis. Lack of wealth means medical bills are more likely to present a financial hardship when they hit Black families, more so than white families. Then chronic conditions that are a result of systemic racism and also perpetuated by systemic racism also lead to increased medical debt. Those with chronic conditions report more medical debt than other folks, and Black people are more disparately impacted by chronic conditions. So there's a lot that I can say about the specific ways that medical debt shows up and its racial impacts. I will emphasize that since I am based in the South here in Atlanta, it's important to recognize that households in the South, which is the region with the highest concentration of Black people, carry more medical debt than households in the Midwest, West, or Northeast. And racial inequity underlies all of those disparities. It's no surprise that Jim Crow South still is reflected in the way that we see medical debt and hospital access. So although Jim Crow hospital segregation is largely a thing of the past, it played a crucial role in the current health disparities that we see, the negative health outcomes and chronic conditions, the healthcare quality and access issues in Black communities. That legacy of segregation isn't limited to the South. It showed up in its own way in northern states. But that legacy of segregation in healthcare underlies all of these racial health gaps that we're seeing. It underlies all these negative health outcomes that we're seeing. In terms of some of my frontline experience, I previously worked at a consumer watchdog organization here in Atlanta called Georgia Watch. And we operated a consumer hotline where consumers regularly called us from around the state with all kinds of issues, energy bills, but also medical bills. And medical bills were the majority of our calls, actually. And what we saw were people calling with insurance issues, trying to figure out how to get insurance, trying to figure out how to navigate necessary procedures despite lacking insurance. And then folks who were insured, who thought they'd done everything they needed to do to avoid a bill, who still ended up dealing with mounting medical bills. There was a stark difference in who called us overwhelmingly about medical bills. It was Black folks in particular. We did have some, white consumers who called us, some of them affluent, some of them not. But it was overwhelmingly lower income Black folks who were calling us with medical bills. So some of the things I've seen firsthand definitely verify and confirm that we have a real systemic racism problem as it relates to medical debt, which shouldn't really shock anyone. But I will stop there because I know there's much more that I could say, and we want to have some time for the other panelists to speak.
Thank you so much for that perspective, Bernita. Let me turn next to Jared Walker, the founder of $4. If you folks out there don't know Jared, he's started a really fascinating effort to really assist patients at the grassroots trying to get financial assistance from hospitals, which is enough to sustain not only his work, but I think he has a small army around the country now who are assisting in this work, which I think in many ways is just an incredibly powerful testament to the systemic problem that we have here. Jared, you want to talk a little bit about kind of $4 and what you have seen, really on the front lines, trying to help people navigate the system and either avoid debt or, if they are in debt already, get some relief from medical centers.
Yeah, thank you so much. Happy to be here. Thanks for having me. I started $4 after watching my own family go through medical crisis and wanted to help people hopefully relieve the financial burden of that. And I, started advocating for patients to get charity care at hospitals. I had no idea that was a thing. Spent years crowdfunding to help people pay medical bills, and then realized, oh my gosh, there's this program out there that nobody knows about, and it was a little frustrating for me. And I've kind of come to know that most patients don't know about charity care and financial assistance and how hospitals have to have these programs to keep their nonprofit status. And the result of that is millions and millions of people are declaring bankruptcy or on payment plans for medical bills that they shouldn't have to pay. So we have a army of patient advocates throughout the country, a handful of staff members that advocate for patients, fill out the necessary paperwork, submit it to the hospital, do the follow-up. We do this all completely free. We've just hit $20 million in medical debt relief for people throughout the country, and we've completed thousands and thousands of these applications. And it is not easy, and I can go on and on about that, which I'm sure we'll get into. But that's a little bit about $4.
Thanks very much for that, Jared. Yeah, I'm looking forward to getting into some of this. I'm sure you have many stories to tell. Ray, last but certainly not least, Ray Klunder is a researcher at Harvard Business School who's looked extensively at the scale and scope of this debt problem, and also maybe most relevant to this conversation, kind of how that debt and how access to assistance actually shapes patients' behavior. Ray, do you want to talk a little bit about the research that you've done and kind of what you've seen in kind of what this means for patients who are having to live with this?
Yeah, absolutely. So terrific to be here. It's so fun to watch kind of RIP grow a little bit year by year. So let me just start with a few facts about just the scale of the problem. So in a research paper, we found that, I think everyone here has a good sense, but 1 in 5 Americans has a medical debt in collections, and the kind of amount of medical debt in the United States totals around $140 billion. And while this number is huge and a lot bigger than the number you might remember from the Bernie Sanders campaign, where their kind of best estimates at the time were around $81 billion. But this is kind of a wild underestimate of how much medical debt is likely to be out there, because this relies on the hospital deciding to send that debt to collections, and for that third-party debt collector to go through the hassle of reporting it to the major credit bureau that we were working with. And then to Bernita's points, this kind of problem is geographically kind of varies a ton across the country, right? So to Bernita's point exactly, there's nearly 4 times as much medical debt and collections per person in the South than there is in the Northeast. And so it's just kind of a massive problem with massive scale. And it's exciting to see kind of, all the folks on this call and RIP kind of continuing to make progress, both kind of, getting their hands dirty, like Jared, and, also kind of starting to kind of build out this bigger, policy advocacy apparatus as well. I think my kind of surprise at these financial assistance programs mirrors Jared's, and I was really kind of surprised at this patchwork system, that the kind of financial assistance programs were designed to fill in these gaps where kind of people who are maybe slightly too wealthy to kind of qualify for Medicaid, but maybe don't have super generous insurance or have high copays and high deductibles, but relatively lower incomes, are supposed to get help from these hospital financial assistance programs. And so, as one project, we kind of looked into the efficacy of these financial assistance programs. So we worked with Kaiser Permanente in Northern California to help them evaluate kind of the impact of their financial assistance program on whether or not people were seeking the follow-up care that they needed. And what we found was really surprising. So we found that, we looked at patients just above and just below this 350% of the federal poverty line, which is the kind of qualification threshold to qualify for the financial assistance program at Kaiser. For reference, that's around $100,000 a year for a family of 4 in terms of that income cutoff. And what we found is that even these kind of reasonably well-off households, not the kinds of households that we typically think of as suffering from kind of serious financial distress, we were seeing increases in follow-up care of around 20% just by kind of qualifying for this financial assistance program. And that included kind of increasing detection of treatment-sensitive conditions like diabetes and depression, increases in take-up and filling of prescription drugs. And so this is having kind of a really big impact. So it's exciting to be here with these folks kind of getting their hands dirty, and actually looking forward to hearing more from Jared and Bernita, and then I think have some stuff that's related to Venus too. But I'll stop there for now.
Great, thank you for that, Ray. And I mean, in some ways, your work is on the sort of the other side of the mirror from Dr. Shankran's in some sense, and I want to get to sort of some of the more promising implications of what you just talked about. But let's go back for a minute, if we can, to what you were talking about, Dr. Shankran, because your research, I mean, really sort of gets at not only the financial strains that are associated with a cancer diagnosis, but also the way that patients change their behavior, right, as a result of being forced into debt. I mean, this has very tangible and pretty troubling impact on the way patients seek care, even for really dangerous conditions like cancer, right?
Oh yeah, that's absolutely true, and Ray kind of hit the nail on the head with some of the implications in terms of outcomes. So, I've seen this clinically very commonly. Non-adherence to treatment is a big issue. It's not just refusing care entirely, but being plugged into care and starting treatment, but then falling off. So there are a number of studies that looked at, the extent to which patients with cancer or other chronic conditions stop filling prescriptions for high-cost drugs over time, and obviously the downstream effects of that. We did a study looking at the association between bankruptcy filing in patients in Washington state with cancer on mortality, and people who had cancer who filed for bankruptcy were over 2.5 times more likely to die from their cancer than people without who did not file for bankruptcy. So you can imagine, there are a lot of mechanisms that might explain that association. There's impacts on caregivers, so increased caregiver burden, decreased quality of life in both patients and caregivers. And there are some studies now showing that people who are facing medical debt and other financial challenges during care, during cancer treatment specifically, can actually end up using the ED and hospital more, basically due to a number of factors, including stress on the caregivers and just lack of bandwidth to come in for clinic visits and manage a lot of these issues outpatient. And you can imagine, just in terms of kind of the lens from overall healthcare costs, the investment in trying to help patients and families navigate cancer and the financial aspects of it could have potentially downstream cost savings from an overall healthcare cost perspective.
And Bernita, I mean, we just spent some time down in Knoxville, Tennessee, for the next installment in our series on medical debt, looking specifically at this issue of racial disparities and the cycle that you were talking about. And one thing that really jumped out at me is the degree to which the sort of financial strains of debt related to medical care has this sort of cloud almost that it casts over, it seems, many Black communities in this country. Talk to us a little bit more about sort of how you've seen that impact on mental health, on sort of upward mobility. I mean, it's devastating, isn't it?
It is. It's absolutely devastating. Carrying any sort of debt causes psychological distress. The fear of never being able to pay the debt, dealing with aggressive debt collectors. Mind you, debt collectors contact Black folks at a higher rate than any other demo. Sometimes that's based on zip code data. We live in a very segregated country still, so zip code data is very indicative of the racial demographic that's probably living there. But according to the FTC, debt collectors do contact Black folks at a higher rate than other groups. So the psychological stress of dealing with debt collectors constantly contacting you, the stress of just trying to figure out how to navigate a chronic condition and manage to pay all your bills, choosing between groceries and rent or your medical bill. It may come as a sad surprise to know that Black adults are already more likely to experience feelings of sadness and hopelessness than white adults, and then medical debt really compounds that phenomenon. So in that sense, medical debt directly contributes to poor health outcomes in Black communities, the physical and psychological health outcomes. Now, on the financial side of things, as we know, medical debt affects credit reports. As we know, credit is important for everything, including employment, renting, housing, getting a loan for a mortgage or an auto loan. So medical debt has a way of particularly reinforcing the racial wealth gap by locking Black families out of opportunities to build wealth, right? Aggressive medical debt collection practices include lawsuits to garnish wages, property liens on homes in some cases, and even civil arrest warrants for unpaid medical bills, attaching or seizing bank accounts. All of this disparately impacting Black families who are already left behind in a lot of ways in terms of wealth. So to avoid these consequences, a lot of times, as was mentioned already, individuals will avoid healthcare entirely when it's extremely important that they go ahead and get it sooner than later. Avoiding it just delays the cost down the road. Sometimes individuals drain their short-term savings, what little they have. They increase their credit card debt. They dip into any sort of long-term savings accounts like retirement or college funds, all to pay off these burdensome medical bills. And not to mention, and I would be remiss not to mention it, families turning to these deceptive financial products like title loans, car title loans, which is an industry that clusters in Black communities. So as you can see, there's sort of this whole cycle that folks find themselves trapped in, and medical debt just exacerbates the problem in every single way. The last thing I'll mention is what Ray indicated about folks not knowing that charity care even exists. So many of folks who are dealing with these debts literally would have been, debt-free were they even aware that they had access to charity care or financial assistance. And the financial assistance programs we do see in some states like Tennessee and Georgia can tend to be kind of restrictive compared to those we see in states that are farther north that did expand Medicaid and so forth. So I won't belabor it, but suffice to say, the way medical debt just feeds into this vicious cycle and just creates this ballooning of issues is really stark in its impact on Black folks, and it's a tragedy, and this shouldn't be something that folks are dealing with.
Yeah. Thank you for that, Bernita. I mean, Jared, it really when I heard at first what you were doing, I thought of that that old story of the Dutch boy who puts his finger in the dike to try to hold back the sea, and I see you out there doing this work because the system is obviously not working. You mentioned people don't know about financial assistance. Even if they apply for financial assistance, they have to jump through innumerable hurdles to get it. Talk to us a little bit about kind of how that system is failing, assuming you would agree with that characterization.
Yeah, definitely. I mean, I think so. The first thing is, people don't know about this, which I mentioned. So millions of people are on payment plans for bills they don't have to pay. And so at $4, we're trying to make charity care known, easy, and fair. And right now, nobody knows about it. That's a problem. Why don't people know about it? Well, right now, I always throw out the challenge of go to your hospital's homepage and try to find the financial assistance policy. Try to find the application. Most likely you won't. There's not a button on the homepage for financial assistance. You have to know what you're looking for. Usually you have to use Google to, find your hospital name plus financial assistance, find the paperwork, and it's challenging. And then there are a lot of barriers where hospitals will make you talk to a financial counselor before they'll even consider you for financial assistance. And so it's not being told to people. We always ask our patients, did the hospital tell you about this program? And the answer is always no. So nobody knows about it. Then is it easy? Well, not even close. I think last time we looked at the numbers, it was close to like over 90% of all hospitals are going to require you to either mainly fax in your applications. Like that is how they want to receive these applications or mail them in. And they're asking you for, 3 months bank statements, 3 months pay stubs, last year's tax return, proof of residency, proof of employment. You're getting 60, 70 pages together and having to mail these in. Then you may as well flip a coin to see if the hospital gets it. So it's like the barriers to even once you know about it, it's like, okay, hooray. Well, how do I get it? How do I access this? And it's not accessible. So a lot of times, they'll ask for things that they may or may not need, or you're going to be sitting on hold and unnecessary, hold times, wait times, call the hospital a whole bunch of times. And then, so it's not easy. And then the other thing that's frustrating about it is like, well, who does qualify? The biggest misconception, I hear people say, oh, well, that's not for me. I didn't qualify for food stamps, so I'm not going to qualify for this, where it's much more generous than a lot of these other programs. some of these I've seen go up to 600% of the federal poverty guidelines. Like, this isn't just for you know the poorest population. Like, that these programs can be pretty generous. It's just people don't know about them. And then at the end of the day, it's that the burden is on the patient to find out and navigate these programs, instead of it being on the hospital to tell patients about it. And I can go on, but it's a problem.
I mean, I can certainly confirm, having done some research in this as well, that good luck trying to find these policies. One of the more amusing phenomenon that we've I don't know if that we've discovered in trying to research these policies is that it's even hard to find people at these hospitals who know their own policies, let alone expect that patients would be able to find them. Ray, your research suggests that if these policies are implemented with any degree of efficiency, and I don't want to hold Kaiser Permanente up necessarily. To be clear, KHN is not affiliated with Kaiser Permanente in any way. And also, having looked at Kaiser Permanente's policies, I can say that they're not the easiest to find or to navigate either. But they obviously have managed to get some of their patients in there, and they have had some positive impact. Can you talk a little further about what the implications of what your findings might be in terms of thinking about how patients can be spared at least some of the burden of medical debt?
Yeah, let me start by kind of framing, going back to one of Vina's original points, which is that it's really important, at least for me, to remember that when people are finding themselves experiencing a hospitalization at a terrible time, like they're actually staying over in the hospital, receiving care, and in some prior work we found that a hospitalization results in a 20% reduction in your earnings, in the subsequent years, and that this is a really persistent decline. So this sticks for a long time. So it's just to start by saying, this is hitting people at a point where they are kind of the least capable of dealing with this financially. They can't just kind of expand their hours or something. And then going back to the kind of financial assistance effects. So the Kaiser program, I think it's really important to think about the two different components of it, right? So the first component is this debt forgiveness. So they basically relieve all of the past bills from this kind of episode of care. And then they also remove all cost sharing requirements over the next 6 to 12 months. And so this is kind of the typical structure that these financial assistance programs take, but there are these kind of two distinct, at least from my perspective as an economist, kind of forces here. And so I think the bottom line from that project is, look, like, people aren't getting the care that they need. If you're not detecting diabetes because you're not, feeling financially secure enough to seek the follow-on care and actually get tested for it, then we're kind of missing out on kind of some potentially big and important health gains from these kind of treatable healthcare conditions. And then, I think I want to try to think about, and maybe this is like a nice segue into some of the work that we're doing with RIP, is, like, how do we, separate out that kind of cost sharing piece, which is kind of similar to what you get from enrolling in Medicaid, where you're kind of not responsible for your medical bills going forward, or you kind of don't have these copays that you can't afford, and this debt relief piece. So this goes back to some kind of what Bernita was talking about in terms of, there's this kind of this hanging kind of dread from this debt that you're unable to pay, and so I'm happy to talk more about this, in the kind of rest of our time here. But so we've been working with RIP to try to disentangle just what does that debt relief piece actually do, and kind of how does that debt relief help kind of improve the outcomes that we've been discussing here.
Thanks for that, and I think that is a nice transition. I mean, because I think when I'm certainly pleased, as I'm sure all of you are, that sort of this issue is getting more attention here in Washington and in state capitals around the country, as people recognize just how dangerous medical debt is. But forgiveness tends to be the sort of place that we seem to want to go because it sort of seems to require less systemic change. That's what we did with with student loan debt. But as we saw in the discussion of student loan debt, you can forgive all the debt you want, but if you don't change the system, you're going to have a whole new generation of people coming up right behind that are stuck with debt as well. But let's spend a minute talking for a second about forgiveness and what the potential impact would be for patients on that. I guess I'll throw it out to all of you to see if you had thoughts on sort of how important would some sort of forgiveness regime be for folks, and how would you see that playing out? And I guess raise your hand if you want to take a shot at that one first. Anyone? All right, Bernita, go for it.
Yeah, I'm happy to take a stab at that one. I am 100% behind the notion of forgiveness, although we prefer the term cancellation to take away any sort of moral connection to the idea of medical debt or any debt. But cancellation of medical debt has to be paired, to really be effective, it has to be paired with some of these systemic changes that you're speaking of, Noam. Things like expanding Medicaid in holdout states, finding a way to expand Medicaid in those states that have refused to expand. Most of those states that have refused to expand are southern states, where so much of the Black population resides. It requires improving financial assistance as the requirements are laid out in the ACA, requiring screening upfront for financial assistance. For instance, hospitals are not required to screen patients. So that's the reason why so many patients are not aware that they have access to it or potentially have access to it. Changes that would involve reducing some of the types of aggressive debt collection activities that the collectors can engage in, prohibiting certain kinds of debt collection entirely. We've seen that happen at the state level, with some states actually passing laws that prohibit wage garnishment or property liens against homes for a medical debt. So I think cancellation is really, really important. And I think we'd be remiss to not discuss it when we're discussing some of these other structural changes that are necessary. Because we could expand Medicaid tomorrow in Georgia, but that's still not going to fully help some of the folks who are dealing with thousands and thousands of dollars in medical debt and trying to figure out how to pay that plus their rent, plus their groceries and so forth.
Dr. Shankman or Jared, you want to weigh in on forgiveness before we get to kind of structural change?
Yeah, absolutely. I'll just comment. I fully agree with what Bernita just said, and I think we all can recognize it's really a multifactorial problem. I mean, there's absolutely a lack of transparency about medical costs and opportunities for assistance with medical costs during care. That definitely needs to change. But, especially lower income people are coming to cancer diagnosis or any major health illness diagnosis with financial circumstances and social needs, and failing to recognize that, a lot of the assistance that these folks need might be around transportation and food and addressing, prior debts so that they can afford care is critically important.
And Jared, any thoughts on, I'm sorry, I should have used Bernita's terminology as well, which I think is much better, around cancellation?
Yeah, I will just throw in my things are just little anecdotes of folks that we've been able to help. You see this, it bleeds into everything. So a medical bill shouldn't be something that gets between you and your education, putting food on the table, your employment, but it does. We see it every day. Medical bills ruin my credit. I can't get a loan. I can't get a car. I don't have transportation to work. We see people all the time that are faced with the decision between a medical bill and their education. And when you're able to cancel these medical debts, people get to graduate. People get to keep their jobs. People get, there's all of these things that it affects. And we see that all the time. Because this medical bill was waived, I got to continue my education. That is insane that people are faced with those decisions. So, the importance is everything.
Yeah, that's really profound, and And I guess in some ways not surprising. People are living with this enormous weight. One of the questions we asked in the poll that we did with our brethren at KFF about medical debt was, and others have asked these questions as well, about how large a bill people could pay, and the Fed has done research on this as well. A majority of Americans say that they don't have $500 lying around for an unexpected medical bill, and when the when the average deductible on a commercially insured health plan is in the thousands of dollars, I used to joke it doesn't take a Nobel Prize in economics to realize that that's going to be a problem. And it does beg the question, I think, which I want to put to all of you, which is more systemically, as long as the system requires substantial cost sharing from patients and patients don't have ready reserves of cash to pay, we're going to continue to be in this problem, won't we? Maybe that's just a simple yes. I don't know. Does
Yeah,
anybody want to?
we we absolutely will continue to have this problem as long as patients are still required to shoulder some share of the cost of healthcare. I mean, it's very important, as I mentioned, to do things like expand Medicaid and holdout states, improve charity care requirements in the ACA, crack down on some of the ways that debt collectors pursue these debts. But we need to be talking about the elephant in the room, which is that other countries have figured out how to not have this kind of system such that they don't have these kinds of medical debt problems. Canceling medical debt, yes, but single payer universal health care is a crucial part of the solution here. Enacting some sort of universal publicly funded national single payer health plan that's administered at the state and local levels with comprehensive lifetime benefits, dental, vision, you name it, will go a long way to ending this problem. We've seen some states we've seen one state try to do that on some level, more of a public option than actual single payer, and that's California. And they failed at the task a couple of times as they've attempted to pass some sort of public option or single payer. But that needs to be a major part of this discussion, because otherwise we will be kind of band-aiding the problem and kicking the can down the road in some ways.
I mean, Ray, from a research perspective, I mean, there has been some interesting research, right, about Medicaid expansion and sort of what that has done, essentially removing out-of-pocket costs for a low-income population. I think there's been some work done in California and some other states. It's actually pretty profound what happens when you remove that cost sharing, right?
Yeah, look, I mean, we know that health insurance works, right? It's not, that shouldn't be rocket science. I think, whether you go back to the Oregon, health insurance experiment, which kind of showed that, people are more likely to seek care. They're less likely to suffer from depression. They're much better off financially. And there are all kinds of these, additional benefits that come from, having the security of health insurance. Whether we,
Ray, let me just interrupt you. I mean,
yeah, go ahead.
Sorry, but I mean, not just health insurance, right? I mean, health insurance that limits out-of-pocket costs for patients, because, I mean, most of America has health insurance now. The problem is that they can't afford the cost sharing that's associated with their coverage, right?
Yeah, I think that's right. Although if you look at something like Medicare, which has a kind of considerable cost sharing component, like there is, a lot less medical debt in the kind of, that results from a hospitalization if you are someone who qualifies for Medicare. So you're 65 or older. Of course, it's even better if you have something like Medicaid. But, I'm also sensitive to the problem that hospitals are trying to solve, particularly in the kind of lowest income communities. Like those are really hard, businesses to be running. And, I think there's also a role that the United States plays in kind of basically shouldering the costs, and often in these wildly inefficient ways on the backs of kind of the communities that can kind of least afford to bear these costs. but in terms of driving innovation, in the pharmaceutical sector and in terms of treatments, so I think the U.S. is world class, but there is a bit of a trade-off there that I think should be considered. But in terms of the way that things are structured now, we just have every single type of healthcare system under the sun, whether you want to look at kind of Medicaid or VA or Medicare Advantage or Medicare or employer-sponsored insurance or the health insurance exchanges. Like, we have all of the different healthcare systems, and part of the reason that kind of it's so opaque to patients is that the kind of administration piece of this is such a mess. And hospitals are spending so much money on kind of figuring out coding and billing for all of these different systems. And so I do think, to Bernita's point, that like something that actually consolidates the way that we're paying for these things and is also kind of thoughtfully incentivizing innovation would be, I think a very difficult challenge to tackle, but one that would have just enormous dividends for all of the issues that we're talking about.
Jared, I mean, for starters, you mentioned this earlier in terms of how financial assistance works. I mean, not only are people not aware of it, but our research, and I know you found the same thing, suggests there's just wildly different practices around the country. So, I mean, if you get in a car accident and you're taken to one hospital, you might get a full ride even if you're making 4 times the federal poverty level. Down the street, you're not going to qualify, and they might sue you if you don't pay. I mean, there's this huge variation, which I assume is contributing to the problems that patients have understanding this. To what extent do you think just simplifying with a more rational national standard around who should qualify for financial assistance from hospitals, to what extent would that help, do you think?
Yeah, it would help tremendously. I think, what we know about charity care is that, nonprofit hospitals have to have it. They have to have a policy. What that policy says ranges, from hospital to hospital and state to state. And the biggest project that we've ever had to take on was trying to find the financial assistance policy data for every hospital in the country because nothing is standardized. And every single hospital is going to have something different. So yeah, most of them will say, okay, we'll waive 100% of your medical bills if you're at or below 200% of the federal poverty guidelines, and then we'll have a sliding scale for a discount from 200 to 300%. That's pretty standard. But then you get into the weeds on, well, do you have insurance? Because if you have any type of insurance, you're not eligible. If your medical bill is not, at least $2,500, then, well, we can't help you there either because we have a minimum bill requirement. What assets do you have? Do you live in the state? What zip code do you live in? Are you in our county? Then you get into all of these other things that some are just flat out illegal, and hospitals can't do that. But who's checking them on it? So having these things being standardized would be enormously helpful for patients, and it sure as hell would be helpful for my organization because we wouldn't have to dig through all these different policies for each and every single patient. It would be a huge win.
I'm sure there'd still be a lot of work for you guys. I mean, Dr. Shankwin, I mean, you're in Washington State, which has taken a stab at trying to put in place some standards around financial assistance. I think it's relatively recently since that new law went into effect, but are you able to discern any impact, or have you heard from any of your colleagues about whether or not that's made it any easier for patients who are sort of trying to navigate this?
Well, I haven't. I can speak to just generally that in Washington State, I think, we have we expanded Medicaid early. There's definitely state policies in place that are favorable, especially for lower income people. The notion of cost sharing, I just wanted to get back to this concept in cancer care specifically. I think really I'd be hard pressed to know if this has any benefit in terms of resource utilization at all. I think we definitely see the downside of it in terms of non-adherence. I think especially in diseases like cancer, where, people are cost sharing for visits related to chemotherapy that makes them sick makes very little sense. No, I'm sorry, I maybe probably didn't answer your question, but I think Washington State. Yeah, I think Washington State in general is on the leading edge in terms of policies and protections, but still there's a lot of room to grow. We definitely are seeing significant issues with access, quality, cost sharing, medical debt in our population. In spite of that, and I would even argue that in terms of low income individuals in particular, it's not just cancellation of medical debt, but perhaps programs around guaranteed income or sequential payments for people who are newly diagnosed, because this is a time when people are completely vulnerable and overwhelmed. It's very hard for people to engage with financial navigators in the clinic, even around accessing existing programs, and oftentimes there's eligibility issues. So I think just that's an area I know several research groups around the country are interested in, guaranteed income or payments for people who are newly diagnosed with cancer.
Thanks for that. So we're getting down to the end of the hour here, and I want to leave just a couple of minutes here for everyone to give some last minute reflections on sort of laying the groundwork for kind of policy interventions that might address some of these issues. We've obviously been talking about some of these, but maybe we can go around the virtual table one last time, and if there's sort of another idea or two that you want to get out there that you think would, from a patient perspective, really have an impact, now's your chance. So Ray, you want to start?
Sure. So, I think we've talked a lot about kind of the impacts of medical debt itself, but I just kind of want to, harken back a little bit to the kind of broader economic challenges that people are facing in the midst of a health crisis, right? So, if you're losing 20% of your income on average, like, we don't have any kind of short-term sick leave or disability insurance that is anywhere near universal. So, just a tiny share of employers have some kind of disability insurance policy. And, I just want to kind of plug the importance of having that kind of income insurance in addition to kind of helping to protect patients along these medical debt dimensions.
That's an interesting, important point. Bernita, do you want to take a shot at it next?
Yeah, and I'm happy to reiterate a couple of things I've already said. I think that we've already seen some interesting efforts underway at the federal level, and that's great, but we definitely need more robust solutions, and we need solutions that prioritize relief for Black families as well, as they are disproportionately impacted. And so I'll repeat, improving the ACA to expand the FAP, the financial assistance policy requirements, to require screening. Those requirements should also apply to for-profit hospitals as well. Creating some sort of federal program that maybe would allow the Centers for Medicare and Medicaid Services to offer some sort of Medicaid-like plan to those who are eligible in states that have refused to expand Medicaid. We can't constantly leave this up to the states. Incorporating medical debt cancellation and Medicaid expansion into a larger strategy towards reparations for racial justice. Reparations for racial justice discussions have already involved conversations around student loan cancellation. So I think medical debt cancellation needs to be part of that conversation. Discharging medical debt, as RIP medical debt is already doing, canceling at some higher level so that folks just don't have to deal with these thousands of dollars in bills that they just simply shouldn't have. And the last thing I'll say is enacting some sort of universal publicly funded system that gets rid of some of the cost sharing problems that we have that contribute to all of these issues. We have that in the form of the veterans healthcare system, which I'm always envious because my husband uses it and pretty much never has to worry about a medical bill, which makes me very, very envious. But I'll stop there and just say that there are a lot of solutions, and there's not going to be a one solution. Even single payer on its own isn't good enough. We need cancellation of medical debt. But I'm hoping that as the conversations continue, that we'll eventually get to solutions.
Great. Thank you. Thank you for that, Bernita. Jared, any closing thoughts, prescriptions?
Yeah, I'll just echo what Bernita said. I mean, yeah, screening financial assistance. I will only speak about charity care and financial assistance since that's what I feel like I know. It needs to be standardized. The application should be the same. There shouldn't be 7,000 different applications floating around for each hospital. And then the accountability, that there's really no accountability there. And unfortunately, we see hospitals have illegal things in their policies all the time. And it's just, who's going to call them on it? So we need accountability and certain things to be standardized. That's what I got.
Great. Thank you. Thank you. And last word goes to you, Dr. Shankran. I know you mentioned a few things already, but anything else you want to add before we wrap it up here?
Oh, I fully agree with what everyone has said. I can kind of just bring it back to the sort of the clinical world and what we as a clinical community can focus on. I think the big things are, recognition that this is a huge problem that affects all people, even those we think are not at risk for financial hardship can be, can suffer substantially. Insurance does not protect people from financial hardship during treatment. With that recognition, I think we can move forward with screening people longitudinally during their care for social needs and financial issues, navigating them through those things, and also incorporating the providers into the decision making. And to do that, we need tools that will improve cost transparency, not from just an overall healthcare cost standpoint, but also from a cost sharing standpoint, so that we can actually help people make decisions that are in their financial interests as well as their clinical interests.
Terrific. Well, thank you all very much for your perspectives and for your great ideas. I'm looking now at what's next. I think we have Patients Weigh In, which are some videos starring patients that RIP has put together. So stay tuned for that and for more exciting discussion later this afternoon. Thank you all for joining, and thank you panelists again for all of your work and your perspective. Have a great afternoon, everybody.
Thank you.
I had recurring kidney stones, and I at one point remember facing the fact that I could either go rack up more medical bills or I could just try to care for myself at home. And by doing that, I created a much worse situation where I had a really bad kidney infection. As a result of that, I ended up in the hospital for about 3 days. And of course, that was more of a medical bill than, I had been originally trying to avoid without going to the specialist.
Turns out in 2015, I ended up needing to have back surgery. It was the repercussions of the surgery that ended up putting me in the hospital for 45 days. When I went to the hospital, I had a 102-degree temperature. I would have signed a deal with the devil at that point, had he been the one holding the scalpel to get the thing out of my back. I assume I was close to $500,000 in debt after all was said and done.
So I'd gone for like a routine physical exam, and during the exam, my doctor found what she thought was maybe a knot or something in one of my breasts. My insurance wouldn't actually cover the mammogram itself because they said that I was too young. And so it resulted in me getting an almost $500 bill some months later after I'd already had the ultrasound.
I ended up in a very bad situation where I had to go into the emergency room and I was hospitalized. I was insured at the time, and even after all the treatment and everything, I got hit with the big bill that I couldn't pay off at that time.
I was a single mom. I was going to school full-time. I was working full-time nights and finding myself barely sleeping, honestly. My choices were to either put food on the table for my kids or take care of my health. And I felt that I didn't have the choice to do both at the same time.
I have 4 kids. One of my kids is in college. My credit was so shot because of medical debt, I couldn't even sign for a student loan. How worthless or useless do you feel after that, being a father, when you can't even help your kid go to school to get into the medical field, to help more people? What am I supposed to do?
Any spare savings we had went toward kind of incidental expenses. There wasn't really a lot in the way of spare cash at the time where, you know, if we did get an unexpected expense, we could just throw money at it. That wasn't a thing for us.
I'm always that type of person that whenever I start a job, I make sure that insurance is a priority for me because it just benefits me in the long run. And even after all of that and being well covered and paying so much monthly, some of my special procedures at the time were not from your general doctor, that you had to go be referred to a specialist, and a lot of that wasn't covered. It's a systemic problem. We've just become numbers in the eyes of people that should really be caring for us.
We also have a diabetic child. And so, you know, having a high deductible health plan with someone who needs medicine consistently was really tough.
I went to the military. A lot of things that you deal with are based on financial responsibility, right? So once that's ingrained into you, you have a sense of pride. You get some medical debt, you ain't telling nobody. Now it's a shame when you run your credit and somebody says, oh man, you got 22 lines of collections. They're all from the hospital. And they look at you sideways. Well, you want me to be shamed of staying alive?
It's affecting my self-worth. It's affecting my confidence in everyday situations. It's affecting how I feel about myself as a person. And it's easy to start to feel like you're the only person.
Almost exactly 10 years later to the day, I received a letter from RIP Medical Debt. So I went ahead and opened it, and it let me know that my debt had been abolished. And I was very surprised. It was just beautiful to know that I had been helped in that way unexpectedly.
It was very touching to me when I received those letters in the mail. It made me realize that I wasn't alone, and that there are people who care.
I had seen them before on a segment on Last Week Tonight by John Oliver and thought, hey, that's a cool organization. Like, that's great that they're doing that. And when I received my letter, I was feeling like I just had struck gold. I won the lottery. Having a daughter with leukemia and having to focus on her, repurposing that money instead of just paying off a medical debt that should have been covered in the first place, to prioritize and take care of my daughter has been a blessing in the long run.
As I started a new career in my life, I now am able to help others and show others that they're also not alone.
When did it become shameful to help other people? That part of life as a society, we've grown so far from it.
We only live once, and to put your health aside just because the finances aren't there shouldn't be an option.
I had recurring kidney stones, and I at one point remember facing the fact that I could either go rack up more medical bills or I could just try to care for myself at home. And by doing that, I created a much worse situation where I had a really bad kidney infection. As a result of that, I ended up in the hospital for about 3 days. And of course, that was more of a medical bill than, I had been originally trying to avoid without going to the specialist.
Turns out in 2015, I ended up needing to have back surgery. It was the repercussions of the surgery that ended up putting me in the hospital for 45 days. When I went to the hospital, I had a 102-degree temperature. I would have signed a deal with the devil at that point, had he been the one holding the scalpel to get the thing out of my back. I assume I was close to $500,000 in debt after all was said and done.
So I'd gone for like a routine physical exam, and during the exam, my doctor found what she thought was maybe a knot or something in one of my breasts. My insurance wouldn't actually cover the mammogram itself because they said that I was too young. And so it resulted in me getting an almost $500 bill some months later after I'd already had the ultrasound.
I ended up in a very bad situation where I had to go into the emergency room and I was hospitalized. I was insured at the time, and even after all the treatment and everything, I got hit with the big bill that I couldn't pay off at that time.
I was a single mom. I was going to school full time. I was working full time nights and finding myself barely sleeping, honestly. My choices were to either put food on the table for my kids or take care of my health. And I felt that I didn't have the choice to do both at the same time.
I have 4 kids. One of my kids is in college. My credit was so shot because of medical debt, I couldn't even sign for a student loan. How worthless or useless do you feel after that, being a father, when you can't even help your kid go to school to get into the medical field, to help more people? What am I supposed to do?
Any spare savings we had went toward kind of incidental expenses. There wasn't really a lot in the way of spare cash at the time where, if we did get an unexpected expense, we could just throw money at it. That wasn't a thing for us.
I'm always that type of person that whenever I start a job, I make sure that insurance is a priority for me because it just benefits me in the long run. And even after all of that and being well covered and paying so much monthly, some of my special procedures at the time were not from your general doctor, that you had to go be referred to a specialist, and a lot of that wasn't covered. It's a systemic problem. We've just become numbers in the eyes of the people that should really be caring for us.
We also have a diabetic child. And so, having a high deductible health plan with someone who needs medicine consistently was really tough.
I went to the military. A lot of things that you deal with are based on financial responsibility, right? So once that's ingrained into you, you have a sense of pride. You get some medical debt, you ain't telling nobody. Now it's a shame when you run your credit and somebody says, oh man, you got 22 lines of collections. They're all from the hospital. And they look at you sideways. Well, you want me to be shamed of staying alive?
It's affecting my self-worth. It's affecting my confidence in everyday situations. It's affecting how I feel about myself as a person. And it's easy to start to feel like you're the only person.
Almost exactly 10 years later to the day, I received a letter from RIP Medical Debt. So I went ahead and opened it, and it let me know that my debt had been abolished. And I was very surprised. It was just beautiful to know that I had been helped in that way unexpectedly.
It was very touching to me when I received those letters in the mail. It made me realize that I wasn't alone, and that there are people who care.
I had seen them before on a segment on Last Week Tonight by John Oliver, and thought, hey, that's a cool organization. Like, that's great that they're doing that. And when I received my letter, I was feeling like I just had struck gold. I won the lottery. Having a daughter with leukemia and having to focus on her, repurposing that money instead of just paying off a medical debt that should have been covered in the first place, to prioritize and take care of my daughter has been a blessing in the long run.
As I started a new career in my life, I now am able to help others and show others that they're also not alone.
When did it become shameful to help other people? That part of life as a society, we've grown so far from it.
We only live once, and to put your health aside just because the finances aren't there shouldn't be an option.
Thank you for watching our video of RIP medical debt beneficiaries who courageously shared their stories about medical debt. I'm excited to introduce our final panel of the day, Mission Critical, Key Perspectives on How to Address Medical Debt right now. Our moderator is Kaiser Health News journalist Rachana Pradhan. She is joined by experts Ruth Lande, the Vice President of Hospital Relations at RIP Medical Debt, Dr. Marty Makary, who's Chief Islet Transplant Surgery, Professor of Surgery, Johns Hopkins School of Medicine, and author of the book, The Price We Pay, Michael Waterbury, CEO of GoodRoot, and Catherine Lucas McKay, Associate Director, Insights and Evidence Financial Security Program at the Aspen Institute. Following our final panel, my colleague Priscilla Thomas-Keefe, Vice President of Program Management, will reflect on the day. So without further ado, I will hand it off to Rachana.
Thank you so much, and thank you so much for having me participate in this what I will hope will be a very insightful discussion. So I'm going to just jump right in. I want each of our panelists, if you could talk about what are your top 5 things, pie in the sky here, that if you could do them tomorrow to reduce the burden of medical debt on patients, what would they be from each of your vantage points? Ruth, we'll start with you. How will we kick off?
Right. Thank you so much. And I'm honored to be on the panel and honored to work at RIP. Yeah, magic wand. That is a great thing. I just have to say before I give you my list of 5 things that, so I'm on this panel to represent providers who, when I say providers, hospitals, physician groups, labs, anybody who sends a medical bill. Providers have been put in a terrible situation by this system. They have to fight insurers to justify every treatment and test they want to give. And they also have to bill patients, often unaffordable amounts that may make them sick, as we've been discussing today. And the complexity of the system, which isn't discussed as much, both creates the need for expensive staffing and software, and also creates understandable suspicion and animosity from the public. So that's the backdrop. However, even though providers have been put in a horrible situation, doesn't mean that there's nothing that they can do. And so that's what you're asking me for top 5. All right, number 1, get help to close the communication gap around financial assistance. That's been discussed today. When I say the communication gap, providers put information about financial assistance on every bill that they send to a patient, and then the patients say, I didn't know about it, and the public says they didn't know about it. So how do we close this gap? And the answer is get help from clinicians, from the clinical staff, doctors, sure, but I actually think more nurses, physician assistants, if hospitals have social workers, those are the folks who really spend time with the patients and may identify the need there, the financial need as part of their whole situation, and make sure they can make a direct referral to financial assistance so that the patient doesn't have to do a thing. Also work with community groups who can help get the word out there. So number 1, my magic wand, get help to close the communication gap. Number 2, providers can look at the tools they're using. There are a lot of great tools out there, but look at them. If you're offering a medical credit card to manage payment plans, make sure that it does not charge interest and it doesn't report to credit bureaus. Again, today we've heard a lot about the damage there. And really take a look at when and how you're using these tools and make sure you're taking full advantage of them. Number 3 of my top 5 would be examine your process. Again, we heard some things today, if you were listening earlier, how difficult it is to navigate financial assistance. Make sure that you're really making clear that your financial assistance covers insured and uninsured. A lot of these policies initially were for the uninsured when there were a lot more before the ACA. But now there was a study recently by Crow, which is a company that helps hospitals set their bad debt reserves. And they showed that the majority of hospital bad debt, meaning unpaid stuff, is for insured patients. So needs to be clear that it covers insured folks. Make sure that it's not just mail or fax. Nobody has a fax machine. Nobody has a stamp. Make it easier. And get some stats if you're somebody else on how many people are being denied and why. I heard from Jared Walker, there was a hospital that was denying financial assistance for childbirth because they thought it was elective. I mean, seriously, I did not make that up. So number 4, create a benchmark. So look at what should your benchmark be? And financial people love benchmarks. So look at your bad debt versus charity care numbers if you're a provider, and then compare them with the income in your community. If you're offering free or discounted care up to 400%, what percentage of the community around you has incomes below 400%? Is it 70% of the community out there? Then 70% of your patients should be getting financial assistance. And number 5 may not be obvious, but I think is important, which is treat your billing staff well. In any business, you can't expect to treat your staff poorly and then have them treat the patient, the customer in this case, well. So really listen to those staff, respect them, treat them well if you're going to start to ameliorate what happens to patients in this messed up system. So that's my list of 5 things.
All right, who wants to go next? Maybe Dr. Macri, do you want to take a stab at that?
Sure, and let me just say thank you, and it's really cool to be here with you and Michael and Catherine and Ruth, and I'm a huge fan of RIP Medical Debt, so keep up the good work, and thanks for having me. And I hope this magic wand could actually be a real pen and sign some legislation. But if I were to say things that we need to change in our healthcare system, if we had no barriers or lack of education on these topics or lobbyists that would push against them, I would say, number 1 is payment reform. We've created this system which is not healthy to be practicing medicine in, which is a system where we simply pay doctors for doing more stuff. And we tell hospitals the more stuff they do, the better off they are. And so that entire system needs to be reevaluated. I don't think it's healthy for anybody. Most doctors do the right thing or always try to, but some fraction are going to respond to this insane system where if you recommend no surgery to a patient, you're financially penalized relative to the other options. The second thing I would say is employers need to shop better for health benefits for their employees. They tend to use very cozy relationships and be very risk averse and simply go with the traditional options that they have. And the reality is, as I wrote about in the book, The Price We Pay, is nearly every business in America is getting ripped off on their health benefits spend in ways that are very addressable. No piece of legislation can get them to be wiser in how they shop for health benefits. They need to take this on themselves. And there's many success stories of groups that did that, and they used health plans that are fair, reasonable, and also pay the hospitals and doctors well. Because when we talk about fair payments, we're not talking about low payments. We're talking about payments that pay hospitals and doctors appropriately, but are also compassionate and remember the mission that we have in medicine to care for anybody regardless of their ability to pay. So that's my third wish, and that is that we could have more empathetic, more merciful hospital billing practices. If somebody cannot afford an elective service in America, today it is still extremely difficult to get that elective service done. If you don't have Medicaid or insurance and you have a cancer, say colon cancer, and need to get an operation, good luck finding a hospital that will say, we know we're not going to get paid for this, but we're going to do this operation as part of our charitable mission. Instead, what they do is they ask whether or not you have paid or could qualify for Medicaid or some other form of insurance. And if you don't, they tell you, there's nothing we can offer. To me, community benefit and compassionate care, which is part of a hospital's duty, especially as a nonprofit, means letting somebody know a priori that the care is free or markedly reduced. It's not telling them, well, we'll see, come in, and then they harass you and engage in predatory billing after the care. Third, I would say we should just agree to get rid of all kickbacks in medicine. Let's get rid of secret pricing and let's get rid of all kickbacks. And you would be surprised at the broad consensus in America around these basic reforms. We have been fooled into believing that improving healthcare is a dichotomous political choice, that you're either for or against a particular piece of legislation. But the reality is there's 99% public support for getting rid of secret prices, predatory billing, price gouging, and honest, fair practices, including the elimination of kickbacks in healthcare altogether. And finally, I would hope that people could look for brands that indicate quality on a service basis. For example, the baby-friendly brand, which accreditation that hospitals can achieve, is an indication that they are using many modern-day best practices in delivering babies. And that's healthy, because otherwise we have a system where people are flying blind and using ads at NFL games as an indicator of quality in their local community. So thanks for having me, and those are some quick thoughts.
Great. I want to turn it to Michael now. Michael, would you take a stab at that?
Sure. Thank you for having me. I'm also a very big fan of RIP Medical and really everybody who's trying to address the real challenges that exist out there today in terms of providing, equal and accessible healthcare to everybody in this country. 5 wishes, man. That's I wish I actually had this wand. So I'm going to stay a little practical. Some of the things that maybe we're working on or thinking about. First, I think on the pharmaceutical side, I'd love to see a way to deliver we talk about gross to net pricing. So what the pharmaceutical company charges for the drug, give that net price minus all the discounts, like Dr. McCary said, around kickbacks and otherwise, to the patient. Real time at point of service, no difficult contracts to manage, no rebates that get paid on the end. Just deliver gross to net pricing to the patient when they buy the drug. I think that would go so far and really set us up for success by eliminating a lot of the cost and spread that exists today between the pharmaceutical company and the patient. As I turn more towards the medical side of the house, I think, you've heard a lot about financial assistance today. I think a universal, streamlined financial assistance plan where we could pre-enroll people before they get care based on income levels makes all the sense in the world. And I think a lot of people could get behind. So just automate the process, make it consistent across all states and hopefully easy, and then work through either employers or government agencies or other places to pre-enroll people based on their income levels so that they know if they qualify before they need to get care and potentially go to a nonprofit hospital in their communities to get care. The third thing, and to me, is probably the one that I think is the most practical today in terms of trying to fix this issue. I think sometimes when I look at the system and how it's broken, it's hard to figure out how to fix it, right? We don't think there's really a big bang approach. You have to fix it one system at a time. But I do think when it comes to medical debt, it would be wonderful to have all the data in one place that we could analyze and understand what's causing medical debt. if number 3 on the list is there are no anesthesiologists that participate with any big health insurance company, then at least we could start to identify what that was and do something about it. So a central repository of all the information that we could analyze and then come together as an industry to tackle those issues one by one. And maybe like a secondary component to that is, I think, the players in the industry that are driving some of those challenges should be held accountable for fixing them. And I think so it's sort of a twofold: have the data, analyze the data, and then use the data to hold the industry accountable, whether it's insurance companies, hospitals, pharmaceutical companies, or anybody else, quite frankly, to fix the issues so that patients aren't suffering with medical debt. And I think also you heard a little bit earlier, as my fifth is, I hope that, whether it's employers or patients or really anybody, we do have to increase our level of engagement in terms of our health literacy, our education. The system's very complicated, but I heard one person say that complexity leads to margin, and I think it's somewhat intentional how complicated we made the system. But we have to meet in the middle. We need patients, employers, benefit, HR folks, CFOs, CEOs. Obviously, the brokers are part of the challenge, but we need them to up their game in terms of level of engagement so we can meet in the middle and really make some significant changes to help with medical debt in the country. So those would be my 5. I think, though, it's a great question. I probably could go on for hours, but I appreciate you listening to my ideas.
And Catherine, could you speak about some of the issues on the employer side? Maybe talk about things that you would want to see.
Of course. Yeah, thank you. So first of all, I think that looking at structures where, looking at payment structures, as several folks mentioned already, that focus specifically on how are you going to reduce the costs in the long term of providing the health care that this patient needs, as opposed to the reliance we see on high deductible plans now that is kind of exactly the opposite model of what it takes to get people to use as much primary preventative care, take their meds on a regular basis without having to worry about costs or challenges with getting a refill. Those types of things can make a big difference, and that's something that employers can really do some work on and have a real impact on. Another thing that I think is really important is to think about how you, as an employer, are dealing with the fact that your employees, inevitably, some of them will experience catastrophic costs for something, or even maybe not catastrophic, but just so beyond their ability to handle it within the rhythm of their day-to-day life with the liquid savings that they have. That if you cultivate trust with your workers and you offer some sort of hardship fund, whether it is grants or loans, people will come to you. And there is a lot of stigma around sharing health conditions, of course, but there are some really excellent ways that programs have kind of gotten around that. Similarly, self-insured employers have a lot of creativity that sometimes I don't think they appreciate in terms of, again, how you help the people who are the few that don't do amazing on the standard coverage plan that works for 90% of your employees. And then finally, rather than giving you a fifth thing, I just want to endorse a couple of the things that my colleagues here said around treating billing employees well is so important. And I love that you brought that up because there's an employer relationship there as well. And the way that people come to work is based in some part on how their employer and how their boss comes to work for them. And then finally, getting rid of kickbacks and pricing. Medical debt is one of many types of debt that I study, and we did a lot of work on that at the federal policy level in the mortgage market about a dozen years ago. And while I can't say there's no disparities in mortgage pricing now, they are so much smaller than they were. And really, that's something that, decent legislation can do.
All right, now I'm going to take a somewhat cynical take with my next question, which is, so we just heard a mix of things that could be done from industry alone, seems like, or policy solutions, right? Things that will require legislation at the state and or the federal level to fix. Tell me why some of these things that you all hope would happen are not happening. Specifically, let's tackle from the industry perspective first. Who wants to take a stab at that?
Yeah, I can go first. I mean, I think, I think at times we all sort of want to at least I do, speak the truth and try to sort of force change or encourage change. I think the biggest challenge we see every day is that the big players in the healthcare space have too much power and they focus too much on the short-term financial results of their businesses. It's always hard to get into this debate around it's capitalism, it's a free market, they employ a lot of people, but the bottom line is I think if you're in the healthcare business, you really need to consider the patient definitely high on your list of considerations when you're making any decision. So I think the consolidation of the market, the power that the big players have, the sort of lack of sort of incentive to make any changes because the system's working for them, is probably the main driver, in my opinion. You have a lot of talented people, and we've brought a lot of them into Goodroot that they're smart, they work hard, they have good jobs, but they're incented to deliver better financial results every day in the current system, and that's what they do. It's not that they're bad people or anything like that, but I think we have to figure out a way to create environments for people to bring new ideas to life, to innovate, disrupt, and invest in different paths that that the current ones aren't working. And so I think that's probably, to me, the main reason why you don't see the change that we know is necessary, and we see some of these trends that are very alarming, like increasing medical debt.
Yeah. I guess I would answer that providers, the billing staff I'm talking about, which is the space I worked in for 30 years, I think they feel like they're barely keeping their necks above water. The complexity that happens day to day, which is all based sort of on mistrust of providers, which is why there's prior authorizations for everything. The coding is complex. Every regulation, every payer, the contracts it's just insane. It really is. And I think that there is a sense that you can't do anything. There's just a lot of disempowerment that comes from that level of complexity. Even something good, you think when COVID, there was, that people should not have to pay for certain kinds of COVID testing and treatment. That came out. It was a good thing. I think everybody would agree it's a good thing. Everybody did, except that it wasn't clear who it applied to within the system. It was incredibly resource intensive. And then how you indicated on a claim to somebody, whether you were suspicious that they had COVID. It's mind-boggling how bad it is. And so any solution that we talk about has got to somehow think about that level of complexity. Otherwise, nobody, even with very good intention, and we should always assume good intent, is going to be able to get there.
Dr. McCary, would you want to take a stab at that?
Well, I think there are giant stakeholders in healthcare, and right now, everybody in healthcare is making a lot of money. The system is essentially working as it's designed to have high throughput and also generate wealth. So I am not against profit, but what you have now is a system that needs to be drastically reshaped, and there's not a lot of interest in changing a system that's delivering a lot of money. So I'm looking at healthcare and watching every stakeholder get rich, except for one, and that is the patient. The everyday American worker is paying into this system tons of money every paycheck through health insurance and through tax dollars that go to healthcare in its many hidden forms. And so essentially one of the great qualities of this advocacy work and RIP medical debts work is that you are essentially an advocate for that stakeholder. And I think we need to frame healthcare differently. But to answer your question directly, the reason I think we have not seen these reforms to date is that the system is working for its current stakeholders. Now, there's an attempt in healthcare to want to characterize each stakeholder. Insurance companies want this, hospitals want this, doctors want this, pharma companies want this. The reality is that every organization has its own ethos and value system, often driven by the senior leadership, and they will behave in accordance with the values of that leadership. So there is no one personality type for every stakeholder in healthcare, which is why I think we need to acknowledge that we have good people in healthcare today, but they are good people working in a bad system. It's not a system we designed. It's a system we inherited. And so this is an opportunity for us to say, look, how can we appeal to the best in people and encourage them to recognize that we've changed a lot and we need to remember our true mission. When the polio vaccine was developed by Jonas Salk in 1954, he didn't get a patent on the vaccine. He donated it. And look how far in just one living generation we've come in terms of that altruism in healthcare. So I think many times all we need to do in healthcare is remember our great tradition and our heritage of being compassionate and kind to people in need.
How about you, Catherine?
Yeah, so speaking again, to that employer perspective a little bit more, and just to be honest, also, I'm a worker, and I have chronic illnesses. So I am that 1 in 10 for whom the insurance plan needs some work if it's going to actually keep me healthy. And I think that there's a couple of real barriers to change. One is that because of the way we do and do not talk about money society-wide, not just in healthcare, employers don't realize that easily 40% of their staff does not have a baseline of financial stability in their household. And that means that they have routinely positive cash flow. In general, their expenses are less than their income. It means that they have some amount of liquid savings, ideally at least a couple $1,000s, because that is often the size of something like an unexpected medical bill. And that they have some sort of safety net and some sort of benefits from their jobs as well. 4 in 10 is a lot, and you need to be thinking about that as you're thinking about their costs. But it's something that's just not well enough understood. So that's one thing. Another thing is the issues of stigma around sharing healthcare information with people who are giving you performance reviews or your HR department, as well as sharing information about financial distress. Even when organizations have resources available, it can be really hard for people to go. I think in the video patient testimonials we heard earlier, that came through really clearly, is that the sense of shame that you weren't able to pay your bills, or that you had a heart attack or whatever it is, can really get in the way of being able to get help. And then a final thing is, we've talked about how important it is to get everyone charity care information in a hospital setting, at the point of service, instead of when they get the bill, if they get that information. I think it's something that employers also can think about, is what are the resources, not just that we offer you, but that are available to you if you need them in our community. And that can be things like state policies and local policies, but it can also be things like just knowing to help connect your employees to charity care, and make sure that they know about it up front. And then the last thing that I'll say too is that a lot of the one-size-fits-all needs of running a big company with many employees and running a health insurance company that has plans with dozens or hundreds or thousands of employers is real. But that does not mean that you can't find scalable ways of addressing the unique needs that some people will have. And there are a lot of different ways to do that. I think that some firms have almost like you're having a problem with your insurance concierge, not someone at your like benefits broker, but someone internally who actually like is accountable to you in that they are part of your community and that is a designated part of their job, and you're not just one client. So some of those ideas I think would really help move the needle, and they're all things that employers have kind of at their fingertips.
So I want to piggyback off of, go ahead, Ruth, of course.
I just want to add on, that was just so great, and Catherine, about, and talking about the emotions, the shame that the patients talked about, and definitely from a, we talk about I don't even like to call it charity care, because the word charity is so loaded, and patients don't, they're working, they often have insurance, they don't, I don't need charity, that just, it's very hard for a lot of folks, and they haven't needed assistance anywhere else, and that they need it here. It's just so hard to match up those needs. So that's part of what we're dealing with. And the fact that folks the people who created the high deductible laws and stuff in 2003, they didn't understand that, the basic fragility of the average American household. Yeah.
So Dr. McCary brought up something I want to touch on, right? Which is, we've heard so many stories today of patients just being absolutely devastated by getting caught in this system that's not working for them. So I want to let's start with the provider side. What incentive is there for them to actually change? Maybe Ruth and Dr. McCary can start with that question, because I think a lot of patients would hear all of this and say, okay, so these are things that can be done, but are they being done? And what will it take for it to actually occur?
I think it's really, and again, I know today we're focused on not the big, sweeping policy things, but things that we can all do. And I think providers many of them are doing these things. They need to do them better, because it's become harder and harder. Again, since 2003, the high deductible, the whole structure that is pushing stuff to the patient rather than getting it from the insurer, that does require greater resources to go into getting the word out there in terms of using tools to get people in there. So it's doing that stuff, but doing it more. Some people do it better than others. And I know there's a minority of hospitals who go and sue people and do these really drastic things, and they shouldn't do that. But most do not. So I think providers do want to do it. They need more of it. I think the pressure that we are all doing today, the pressure from the stories that there are ways to do this, it will happen. But it is dire. It is seriously dire.
So 2 observations to build on what Ruth said. One is, many doctors that we have interviewed had no idea that their patients are being harassed with predatory collections. Now, I'm sure some do, and there's no one, characterization of any one stakeholder group in healthcare. But we found that not only were the doctors unaware, but they were livid when they found out that the care that they administered was resulting in price gouging and predatory billing many times, but they had no ability to influence the bill in many cases. Now, at UVA, the doctors collectively spoke up, and they said, look, this is a disgrace to our profession. What you're doing with the billing practices is not right, and they really took a stand. My hope is that doctors nationwide would get engaged on the topic of pricing and collections. They would be able to influence policies to make them more merciful and consistent with the values of the medical profession. Many doctors are on board with that. They're just not aware of what's happening with their own services getting billed out, or they feel that they have no control. And the second observation is that markets are powerful movers in a society. That is, the power of the market is a powerful driver of demand. Right now, I believe there is public demand for honest and fair billing practices, which Ruth appropriately pointed out is being done by hospitals and provider groups around the country. There are groups that are very good about their pricing and billing quality. So we have proposed in the medical literature through the Journal of the American Medical Association and in some ongoing work that we are doing here at Johns Hopkins to promote a simple billing quality score for U.S. hospitals. If they are using honest and fair billing practices, the market should reward that because there is demand in the market. The problem is we've not had a way to create a simple 5-star billing quality score for hospitals. So that's where we are proposing this new system of measuring billing quality, because billing quality is a form of medical quality and financial toxicity is a medical complication.
Yeah, I'd love for you to talk more about that actually, because what would it take really to develop? We have star ratings for other things, of course, in other parts of the healthcare system, even with financial rewards, right? For Medicare Advantage plans is a great example. You get a 5-star rating and you get rewarded with being able to market your plans year round, right? So could you talk about what it would take to institute such a system for billing?
I mean, it
well,
has
first of all,
started.
Yeah.
Oh, go ahead.
Go ahead, please.
I was just going to say Leapfrog has already started this. Leapfrog is a group that that does quality measures, and they have started doing a quality measure based on, I think they call it billing ethics. I don't know. Do you know more about it, Dr. Macri?
Yeah, actually, thank you for saying that, Ruth. We are working with Leapfrog, and it is called billing quality. So please continue. Yeah. Yeah.
No, it's great. I mean, so we're really excited because, yeah, it is. It should be a part of the process. I mean, doctors are not going to understand all the details about how billing works, but there's some stuff that's pretty clear. And the more we can combine the whole process, the financial, the mental health, all the health together, and bring the different parts of the hospital together, I think it'll actually help. You know, we talk about burnout a lot. It's not so much today, but clinician burnout gets talked about it in the press, and I think that really connects. If you feel helpless, that's a part of your burnout. And as a clinician, if you feel helpless to help your patients or suspect that your own organization is not helping in the way that you would like, that's going to contribute to your burnout.
Yeah.
When we talk about the benefits of wealth in my research program, we talk about kind of exactly that one of the benefits of not experiencing financial distress and having the resources to cover the unexpected is really that you have a greater level of health, and that having that feeling of control in your life reinforces that even more. I did want to mention my colleagues have done an amazing project called the Benefits 21 scorecard, and it is a way that employers can apply a scorecard model to the health benefits that they are offering. The Aspen Institute Financial Security Program Benefits 21 scorecard, not written by me, written by some of my amazing colleagues, and that provides tools that employers and HR departments can use to assess whether what they are providing is really effectively meeting their employees' needs and is kind of cost effective given not only their costs, but the workers.
Catherine, could you actually talk a bit about, so I didn't want to leave you out of the incentives question, right? So employers have, of course, a different calculation, but like you said, inertia can be a powerful thing, and also a lot of the times people just get used to what they're used to, right? So could you talk about what incentives businesses and employers have to really change how they structure their benefits and what they're offering their workers to protect them from debt?
Yeah, so one of the things that I talked about earlier is around trust, and just like having an ethos of trusting workers, building trust with workers, ensuring that workers feel that they can trust you is kind of a cultural value premise that I think is very important here. And the way that it comes in with helping people with preventing medical debt is around things like the ability to have an emergency hardship fund that, whether it's zero interest loans or small grants, that people feel comfortable using and know that there will be some sort of confidentiality involved, and that they don't need to worry about people directly involved in their work lives finding out. I think that another like incentive that is really important for employers is throughout the like big business world in the last decade, the concept of financial wellness has really taken hold. There's a lot of work showing that if your employees are like worrying about their money situation all day long, they're performing a little bit less well at work, and they're more likely to, be job hopping. And those are things that really have like significant costs for employers. So the incentive is to help your employees, your workers, be financially healthy. There's a ton of tools out there now to kind of create programs for that I think can like dovetail really nicely with some of the tools that I've mentioned, and other things that folks specifically with the HR expertise around health insurance plans have. But then also just like it bears saying that even in a tight labor market, having health insurance that makes your workers feel like their family is actually in good hands is not super easy, but it's something that will drive employees to leave when it's not there. And the value of keeping people around is just so high, especially right now while it's so hard to find new workers for positions.
Mm-hmm. And I think, Catherine, just to add really quickly, but I think when you talk about employers' incentives, I mean, like it's interesting because the biggest incentive an employer should have is that they have a fiduciary obligation under ERISA to provide, to spend their employees' compensation appropriately, right? And when their compensation includes benefits and they're not doing that, they have a real incentive to make sure that they are meeting their fiduciary obligation to their employees under ERISA. And so it'll be interesting to see when you look at the Consolidation Appropriations Act, CAA, and what happened in the 401k industry for the last 10 to 15 years, what happens in healthcare over the next 3 to 5 years. But, the incentive is clear. Like it is your obligation with your employees' compensation to act as a fiduciary, which means you need to know who's getting paid what, including brokers and PBMs, and you need to make good decisions on behalf of your employees. And if you don't, there are serious ramifications. So it'll be very interesting to see. I think the whole industry has put that pressure on employers, maybe unfairly, because employers are just trying to, like what Catherine was saying, is just trying to provide good benefits and keep their employees happy and productive and healthy. But the obligation is real, and it's very important to make sure you know who's getting paid what, and you're spending their compensation and their benefits fairly and appropriately as the fiduciary. It's very important. So it'll be interesting to see how employers deal with that in the upcoming years here as it becomes more front and center, as there's more people just suffering from debt because they have insurance and the bill didn't seem fair and it didn't provide the coverage they needed or what have you. So I think that should be enough incentive really from the start, but along with all the great things that Catherine outlined. But I think that one should be highlighted because employers are going to start to look at that very seriously over the upcoming years, I believe.
I did want to touch on, I guess, years of reporting in Washington means it's ingrained in me that I need to ask a legislation or policy question. But Michael, I just wondered if you could talk about this. You recently wrote about how 7 states in the last year have passed legislation addressing medical debt. And I wonder if you could talk about, in the short run, is there more momentum at the state level to sort of address this from a legislative perspective?
I mean, I think there are. I mean, one of the things about medical debt that I find very helpful is that I'm sure everybody on this panel, Dr. McCary, Ruth, et cetera, when we talk about healthcare with our family and our friends, people don't understand what we're talking about. I mean, there's so many acronyms. But when you talk about medical debt and surprise bills, everybody understands because pretty much most people have had bills that they don't understand that seem unfair. So I think to answer your question, I think because of that, with all your constituents having this, sort of the pressure and it really being an issue that I think both sides can agree is important. And then you throw on top of the fact that, hospitals that are nonprofit have the benefit of not paying taxes in return for caring for their communities, which they want to do. there really isn't a loser in that entire equation, right? So I do think there's momentum there. I mean, and there's a pretty simple fix from where I sit. It's like streamline the process, make it consistent, and hopefully make it easy, right? Like you got to automate it. We have a company that automates FAP for hospitals where it's just online, answer questions, tells you whether you qualify or not, submit your application, supports you through the process. So I think there is some momentum there. It's always hard to sort of rely on regulation and our political environment, but I hope that that's one that everybody can kind of find a common ground and improve sort of the landscape of how financial assistance can prevent and help this issue of ever increasing medical debt in the country.
Well, and I would like for everyone to weigh on this actually, which is there anywhere where different sectors can find agreement beyond acknowledging that this is a problem, and where are those areas where our various parts of the healthcare system do share some commonality?
I mean, I think first and foremost, I think the common ground is why don't we all work on it together, right? Like just identify that it's a problem and see on it. I mean, clearly, if the top 3 insurance companies made $30 billion last year, we could put some money towards trying to fix medical debt, right? And do it together. Like, let's not villainize anybody in the process, but let's get the major insurance companies, the hospitals, the PBMs, anyone else who we sort of think is in the, I mean, even these sort of doctor groups that are owned by private equity, all these issues, right? Get them to the table with real data, put some resources and some dollars behind figuring this thing out. Why wouldn't we do that, right? I mean, we're all have a stake in this. Let's all get to the table and try to fix it. And then, there aren't any villains if you're actually trying to do that. If you're not willing to do that, then I think that's a problem. So I think we should do everything we can to get all those parties to the table with good data and work to try to fix it. I mean, that just seems like common sense to me. I don't know if full common sense will prevail, but I hope.
Yeah,
unfortunately, right? If only. Ruth, go ahead.
Yeah, if only that's more common. But I think now that medical debt is unfortunately hitting people at a lot of different income levels, not obviously the super rich, but there is more of a sense of how, thank goodness for the reporting and those things that have come out that pointed out how incredibly common it is, that will hopefully lift some feeling and pushing us towards solutions. I agree, we can't stigmatize. It doesn't help to stigmatize. We have to figure out stuff that we can do immediately. And next year, if there's a state regulation, great. If there's something that employers do, great. The providers do, great. That we have to work on this, because if we don't care about each other's basic health, it's not like another consumer good. Healthcare is not like that, and we have to stop pretending that it is. Healthcare is, and we need to care about each other in our communities.
I think, to come at this from a little bit of a different angle, one thing that I have seen as a chronic illness patient in the pain community is patient-led research becoming a force, both for informing industry leaders and practitioners and insurance companies, and also in actually driving knowledge forward from the patient perspective being at the center. And I think that that's something that is likely missing from this space, and that, really could be very valuable. As much as ProPublica is doing, one might say, the Lord's work in publishing surprise billing articles and creating databases of what you can learn, there's nothing like hearing it from people themselves, which is something I think, everyone who just watched the videos before our panel is feeling that right now. And that's something that helps immensely.
Dr. McCary, what do you think?
Well, I think we try oftentimes to come up with a novel solution, but the reality is we've got a model for what works with hospitals that are already doing things well. And the question is, can we encourage, propagate, drive business towards those types of medical centers and create this sense of patient steering will depend on the overall services provided by a medical center, the quality of those services, but also the price of those services in that order. And I think that maybe that is a way we can think about this rather than boiling the ocean. How can we think about incremental ways to reward medical centers that are using good practices today?
Mm-hmm. Well, we've gone through most of our time here, but we do have a few minutes left. So I kind of want to try to end on an optimistic note, despite my journalist tendencies to be a cynic. But I would like each of you to talk about what you feel hopeful about, as far as will this problem actually start to get better, considering all of the forces that are acting against patients at the moment.
I'll say briefly, we never thought.
Go ahead, Dr. McCary.
I'll just be real brief. One thing I'll say is we never thought we'd get the No Surprises Billing Act passed. We never thought we'd get price transparency with broad bipartisan support for hospitals. So we are seeing some really positive momentum. The greatest concern that some of my colleagues in academics and I share in this world is monopoly power of provider groups. We have significant concerns about monopoly pricing and with the effect of mass consolidation on pricing in the United States.
I was going to say too. I mean, I think sometimes we do talk about the negative a lot, but there is a very good payer in this country that supports a lot of people that need healthcare, and it's Medicare. I mean, if anybody has Medicare eligible people that they know, I mean, generally speaking, it performs pretty well, especially if you're sick. So, I mean, I don't know if it's sustainable, but I do think sometimes it's important to take a step back and recognize some positives, and that is, I mean, it's expensive, and all these issues we're talking about are inherent in Medicare as well, and the commercial population's paying for it by subsidizing the cost. But, we get a lot of seniors in our country who are have good coverage and hopefully getting good care. So I think that's a positive, especially when you're dealing with aging parents and those challenges in your life. I mean, I also just think that the dialogue is getting louder. People are speaking up. I mean, just look at the work that RIP Medical has done. It's a good thing. I mean, people are giving them money to help people. We're doing a lot of great work at GoodRoot. We have a lot of smart people that are interested in fixing the system. So I'm encouraged by that every day. So I think there's just I think there's good positive momentum around this issue. And I'm very hopeful that we'll be able to have a meaningful impact.
How about you, Ruth?
Go ahead, Ruth.
Sorry, I injected myself. So who wants to go first?
Oh, okay.
Ruth, go ahead.
Thanks. I think it's a combination. Positive stuff comes from the stories. Certainly at RIP, we do that a lot. But also, Marty, I mean, your book, which I read recently in the beginning, you talk about arriving at a town, about meeting people. Those are the stories that really stay with you. So a combination of making those stories loud so that we can really relate to them, and then looking at small bits of things that work. That's what we need, right? Because otherwise it's like homelessness or some other problem. It just seems so big, we don't know what to do. So we do need to look at things that work, that don't, eliminate the problem, but get us there. And hopefully, in another 5 years, RIP won't be needed, and I'll be working on homelessness or something else.
I think you probably are still going to be needed, but I just wonder would you talk a little bit, just a brief interjection there on, is there an example of something there where you said, maybe one hospital is doing something that could be easily replicated everywhere, or one that actually did after you said, hey, look at what those guys are doing. Why don't you guys do this too? I don't know if there's something kind of tangible that you could point to.
Yeah, I mean, I was at a conference just last week of billing people, and there was this guy. I don't have permission to say who he is, but runs a hospital in the South, and they use a tool to look for people who are eligible for financial assistance, and they do it early on. They do it before they send any bills out, because he said, I don't want to bother any of these people with even one bill, which they might try to pay. And so he just decided to do it early on and save everybody the pain of that. Everybody could do that. That's what he's doing. So, a lot of these things are sort of arcane and behind the scenes, but you can, so sometimes it's not doing something or doing it differently, which will have a huge impact. But I think every single one of us can talk to everybody else in our lives and start to make it understood that this is a really common problem that we all need to work on, and nobody should feel alone or in shame.
Yeah, I think
Catherine, what
very
gives
much
you hope?
very much related to what Ruth shared and what everyone did is, voices are getting louder. There is a real movement around the idea that medical debt in and of itself is just a problem we don't need to have. And it's an entrenched problem. It's not going to be easy to solve. You all know that so well. But the more people who demand a solution to a solvable problem, the closer we get to it. And I think that those voices are coming from a lot of different places. And to be honest, I think that generational change is helping to some degree, because there is a little bit less stigma about saying, hey, I have this problem that seems super unfair that is related to my health, that is related to my medical debt, my student loan, my housing costs. And I think that, I'm no longer the youth, but I think that younger leaders are really committed to not letting problems that are deeply personal for them to be something that they only consider as, a CEO, a Congress person. We all sit in different seats but have similar experiences, and that's something that the more we talk about, the better.
Well, I think that is all the time we have for our discussion today before we're about to transition to a call to action from RIP. But before we do that, I do just want to thank all of our panelists. Thank you so much for bringing your thoughts to this discussion.
Thanks so much.
Yeah, thank you. This is wonderful.
Thank you.
Yeah.
Mom, are you crying?
No, sweetie. Just some allergies. Come here. Let's go play. Come on.
1 in 4 Americans had trouble paying a recent medical bill. Many of these people affected work for companies just like yours. Start giving your employees 100% medical coverage with Catalyze Health.
Good afternoon, everyone. My name is Priscilla Keith, and I'm Vice President of Program Management here at RIP. I would like to thank all of our participants in this highly informative session today. And we have heard very good information about medical debt. We've heard about what the causes of it is and what are some of the recommended system changes. I would like to take this opportunity to talk a little bit about the discussion points in panels 1, 2, and 3, as well as some of the videos that you've seen over this afternoon. Upon review of those discussion points, I will then switch to our President and CEO, Allison Sesso, to close out this program. Medical debt is a social determinant of health. We are increasingly seeing literature designate it as so. In previous literature, as I relate to the CDC and the Kaiser Family Foundation, when we look at social determinants of health, we traditionally think of the environment, we think of workforce development, transportation, health access, and food insecurity. But why is it the case that we're now labeling medical debt as social determinant of health? We've heard from our panelists that medical debt is harmful and patients need help in navigating this complex system. Let's look at some of the points that they've highlighted here. First and foremost, 1 in 5 households carry medical debt. Most households cannot afford a $400 to $500 bill. Most households do not have $400 to $500 in their savings account to even meet this bill. There is also the assumption that the uninsured only carry medical debt. This is far from the truth. The middle income section carries medical debt as well. We've also heard from the Himmelstein study, as well as one of our panelists, Dr. Ray Kluender, in their JAMA article, talk about or highlight that 40% of our constituents are likely to carry medical debt in non-Medicaid expansion states than those in Medicaid expansion states. And as we heard from Benita Hayes, most of those states are in the South, where you find a majority of your people of color, mainly African American population. As such, patients are often labeled as non-compliant when they don't follow through with doctor's orders, as opposed to not being able to come to the doctor's office for fear that they are unable to pay on their medical debt. And in turn, this interferes with the provider-patient relationship. Additionally, we know that mental health related to medical debt is real and lasting. We know that patients suffer from anxiety and stress over their inability to pay their medical debt, which often leads to a delay in care, an exacerbation of illness, or most likely no care at all. We've heard about the stigma of shame in not being able to pay medical debt. And as we know, more than $140 billion of debt is labeled as medical debt. And so when patients feel ashamed of paying their medical debt, they often don't get the care that they need. We know that medical debt is an issue of equity, and I'm going to say health equity. It is an issue of racial justice, as we've heard again, and I will highlight again, that African Americans and people of color are more likely than not to suffer from the ills of having medical debt. We know that it is a matter of economic necessity. In terms of looking at how to reach out with regard to medical debt and to survive this, we know that reviewing charity care, and my colleague Ruth Landy talked about not labeling it as charity care, and so I'm going to talk about it in terms of financial assistance policy. We heard from Jared from $4 that when you talk about financial assistance policies, many of patients don't know that there is such a policy, don't know that they may qualify, and even if they do know about it, the process is so cumbersome that they end up not really finishing out the process to even see if they qualify. So there are barriers to this, and the response to that is that we could make it much easier for people to qualify under the financial assistance policies. We also know that patients are harmed from high deductible health plans. It's been highlighted that 50% of the people who have insurance can't afford these plans. They can't afford that are related to chronic illness, to unexpected health events. We know that most debt is not from health emergencies, but managing chronic illnesses such as diabetes, asthma, and cancer. And so what do we look at here in terms of that? The result is that there is a change in behavior related to how patients will manage their care. I've mentioned before that there is sometimes a non-adherence to treatment, and the patient again is labeled as noncompliance. We heard Dr. Raju talk earlier in the day about a cancer patient that he operated on who could not afford the increase in rent. And so when the patient failed to show up for their chemotherapy sessions, the first thought was, is the patient non-compliant? Why is the patient not showing up? It wasn't because the patient just didn't want to get the treatment. The patient feared that if she left her home, that she would be put out of her apartment because she was unable to pay the rent. So we see the never-ending cycle as it relates to the patient in terms of adherence, the patient in terms of getting the medical care that they need, and the issue of long-term health impact to the patient as well as to their family. We also know that abolishment is only one tool that can help. And we know that it is insufficient. It requires a bigger system change. We know that it's insufficient. But what does that really mean? Big policy solutions are really hard and they're complex. We have multiple stakeholders who are coming at it from their advantage point, and we need everyone to engage and commit to addressing medical debt. So let's highlight that. Is it really forgiveness versus cancellation of the debt? And even if you cancel the debt, does that really solve the problem? We know that when we have medical debt and patients are addressed with that sometimes, more often than not, they're faced with aggressive collection practices. Liens are held against them in terms of their homes. And they often have to resort to, do I need to pay this medical bill? Or do I have to now choose between eating, providing food on the table, providing clothes for my family, or just paying the rent so that I can have a place to stay? Short-term solutions must work toward foundational change, but they are possible, and we have to lift them up. There is really a call to action for all stakeholders, including policymakers, to come to identify ways to eliminate medical debt and to address financial toxicity and the harm that it causes. But what this really means is that we will have to do the hard part. We've heard from the most recent panel a few minutes ago that it really will take everyone coming together, looking at it from not only their advantage point, but that there is a way to address this significant problem. One size does not fit all. And again, as Bernita Hayes said, even if you had a one-payer system, you probably would still have some of the debt. And so I challenge the people on the panel, I challenge the people who are listening to us today to say that not only do we have medical debt and how it impacts healthcare, but we also need to think of it from a holistic perspective, that medical debt should not be an anathema to someone getting care. It is a call to action. I lift that up. RIP Medical Debt is very pleased for your participation today. And we say to you as we go forth, continue to listen to us, continue to follow up with us on our webpage, continue to listen as we recommend systems changes and policy changes to deal with medical debt. It is a problem that is not unsolvable. And I thank you for the opportunity to talk a little bit about what we've heard today. And we challenge you to go forth in terms of solving medical debt. Thank you very much. And now, having identified several discussion points, I'm going to turn it over to the CEO and President, Allison Sesso, to close us out.
Thank you so much, Priscilla, and thank you to all of our panelists to all of you for attending. We hope you learned something new today and were inspired by something you heard. I know that this issue is a tough nut to crack and change will not come easy, but we are seeing greater attention paid to the issue as demonstrated by today and so much thoughtful conversation. We've seen more and more local and state policies and actions being taken to address medical debt. Cook County, for example, has both adopted policy changes to prevent more debt and developed a program that leverages us, RIP medical debt, to address the backlog of medical debt in the area of Cook County and Illinois. And more local governments are reaching out to us for this kind of assistance. So we hope we can get at both the underlying causes as well as picking up the pieces of the broken system that we've been living with. We'll continue our efforts at RIP to be relentless in this discussion and bringing relief to individuals while also being persistent in our work to bring attention to the impacts of the problem on children, families, and individuals. I hope all of you will join us by talking about this issue of medical debt and donating to us also to provide direct relief to families across the country. One thing you can do in the short term is you can share the recording of this event with your friends and families and networks. It'll be posted on our website shortly. So I hope you will post it and let other people take a listen to this important discussion and take this opportunity to tell somebody about something you heard today that was interesting to keep this conversation alive. Thank you again to our sponsor, Catalyze Health, to our supporters, donors, beneficiaries, board, and overall the RIP amazing team. Thank you all for being with us today, and I hope you enjoy the rest of your day. Take care.